Good evening, everybody. A warm welcome to the sixth module of IIP's Basic Bronchoscopy Certification course. The topic today is extremely exciting and also very important. We'll be talking today about whole lung lavage and also bronchoscopy in ICU. So, all the tips and the tricks and all the things that need to be done correctly or could go wrong will be discussed by the best experts in our country. I'm extremely lucky because I have the most accomplished faculty today as my co-faculty, and I want to definitely assure you that today's webinar is going to be definitely one of the bestest webinars you all have attended till date, full of information, full of excitement, full of visual information. So I'd like to start with our talk now. I'd like to invite our speaker, Dr. Vikas Marwa. Dr. Vikas Marwa does not require any introduction whatsoever. He is a consultant pulmonologist and professor and HOD at the Army Hospital RNR Delhi. His areas of interest are NIV, interventional pulmonology, ILD, severe asthma. He has a huge list of achievements and huge list of awards. Best Paper Award at NatCon 2006, at the 4th APCB 2012, Military Award, Sena Medal, Presidential Award, Chief Army Staff Commendation Award, YTS Yorkshire, he got the Best Presentation Award. He has been primary investigator in so many research programs, research things like WHO Solidarity Trial, our COVID vaccine trial, etc. And he's got many publications and many book chapters, and he's reviewer for every good pulmonology journal you can think about. So with this brief introduction, I would like to invite Dr. Vikas Marwa, and he's going to talk to us about whole lung lavage step by step. And while he makes his slides ready, I would really want to thank our academic partners. I would like to thank Mankind, especially Nitin and Mr. Manoj, for their academic support. And I would also want to thank Olympus for being our academic partners. And a big thank you to IIB for always wanting to make sure we have the best academics in IP. So over to you, Dr. Vikas. We look forward to listening to you.
I just request the host to allow me to share my slides, please. Very good evening to all of you. At the outset, I'd like to thank the Indian Association for Bronchology and Dr. Nene for this opportunity to speak on a topic which is quite close to my heart, and we've done some research in this topic. And I'd be speaking more, from the heart and with personal evidence in this talk rather than because it's a rare disease, as you all know, it's an orphan disease, it's a rare disease. There are not much evidence or RCTs available, and the topic given to me is whole lung lavage step by step. So this would be the outline of my talk. After a brief introduction, I briefly discuss the indications of whole lung lavage apart from pulmonary alveolar proteinosis, which you all know, a bit about the technical aspects, and then I'll be discussing the steps in a case-based approach and a brief about the whole lung lavage on ECMO, which we have done few cases this year, and also the role of high flow oxygen post whole lung lavage, and I would be summarizing thereafter. So as we all know that the most common indication for whole lung lavage is pulmonary alveolar proteinosis. But apart from that, there are other indications as well, which most of us haven't heard about or haven't worked much on it. But the evidence is most for primary or pulmonary alveolar proteinosis, which is the autoimmune variant, where we remove the surfactant material. Apart from that, there is case series and case report data on use and utility of whole lung lavage in lipoid pneumonias, acute silicoproteinosis, which is seen in mine workers who work in the silica mines, and as well as in pulmonary alveolar microlithosis. There are few case reports as a salvage therapy. In non-ILD settings, if you look at it, it has been utilized in cystic fibrosis in case of massive mucus plugging and also in inhalational injury, and in some cases as an adjunct in management of diffuse alveolar hemorrhage. But by far, the most common indication is pulmonary alveolar proteinosis, and my talk would be restricted more to this. But if you see the evidence for others, so this data comes from Dr. Ravindra Mehta from Bangalore, where high risk whole lung lavage was done in a patient who had very high oxygen requirement following an unprecedented oil drowning situation, and they were not able to ventilate him. So this was done on ECMO for oil aspiration. And similarly, for acute silicoproteinosis, there are few case reports from the US, and also in exogenous lipoid pneumonia, where physically we remove this inhaled material from the lungs. a bit about the pulmonary alveolar proteinosis. So, as you all know, it's a rare disorder, it's an orphan disease, and the incidence worldwide is 7 cases per million. And I think from our country also, there are not more than 35 to 40 cases which have been published where whole lung lavage has been used. I know the number will be much more than this. And it is essentially a disease with deposition of past positive lipoproteinous material in the distal air spaces, which leads to impaired, oxygenation and presents as hypoxia and dyspnea. So why I've shown you this classification is because alveolar proteinosis is primary, secondary, and congenital, and the role of whole lung lavage is essentially in the autoimmune PAP, which is accounts for 90% of these cases and is the most common kind of pulmonary alveolar proteinosis. And the hallmark is presence of anti-GM-CSF autoantibodies, the test of which is not freely available in the country. When it comes to management of secondary PAP, which is secondary to hematological disorders, malignancies, chronic inflammatory diseases, and certain infections as well, there, the treatment is essentially treatment of the underlying disease. And congenital PAP usually presents to our pulmonary, pediatricians who manage these patients with whole lung lavage. But our experience is more with the adult variant of autoimmune primary PAP. The symptoms, as you all know, autoimmune usually it presents more commonly in male with an insidious presentation in the third to fifth decade, and exertional dyspnea being the most common symptom with chunky, cough and phlegm and non-specific respiratory symptoms. And there may be systemic manifestations with weight loss, fatigue, and there is a very long period of symptom onset to diagnosis. Many a time these patients are treated for various infections, and also most of our patients have already been exhibited ATT by the time they come to us. Hereditary usually presents in late infancy and childhood, and congenital PAP has early onset and very high mortality as the diagnosis is delayed. So this is a disease of paucity of signs. A lot of our audience would be residents, so they have to know that there is clinical radiological dissociation. So the X-rays are pretty bad. The patients are not so unwell, and usually when they present late, they may be hypoxemic, and there's paucity of findings, and maybe having digital clubbing in the advanced stages of disease. In secondary PAP, there will be signs of superimposed infection. So I would be discussing the management and the whole lung lavage on a base on this case vignette where a 39-year-old female, a non-smoker, presented with progressive breathlessness of 1 year duration. So that is the kind of symptom onset which these patients have associated with dry cough, and this was the X-ray. So it is a radiological metaphor where you have a bat wing, and very commonly you find these kind of X-rays in patients who've got cardiogenic pulmonary edema and also in pneumocystis carinii pneumonia, where there is bilateral diffuse symmetric infiltrates in perihilar region in the mid and lower zones in the pericardic region. So this is characteristic. And when you do a HRCT, you get the crazy paving pattern, which is basically ground glass opacities with interlobular septal thickening. And they have geographic distribution with areas of normal appearing lung in between, as you can see in this CT. And this is a signature motif of this disease. Actually, this pattern led to the discovery of the disease. But, crazy paving pulmonary alveolar proteinosis is not the only cause. This is a common question which is asked in exam vivas. There are other conditions and more common conditions like cardiogenic pulmonary edema, which can present with crazy paving, apart from the adenocarcinoma, which is used previously called the bronchoalveolar carcinoma, alveolar hemorrhage, organizing pneumonias, ARDS, and also in pneumocystis pneumonia and lipoid pneumonia, as I've shown few case reports, and occasionally in acute exacerbation of interstitial lung disease. So what I want to drive home to the residents is that if you get crazy paving, it is not always PAP. PAP is much uncommon as compared to these more common entities, especially pulmonary edema, but they will be bilateral pleural effusion. So after you have that X-ray, the CT, what you do next is do a bronchoalveolar lavage, and you get this milky proof, this milky ball which shows a opaque gross appearance with large amounts of sediment. When keep the vial standing for a time, you find that there are globules which settle at the bottom, and on microscopy these are all pass positive, and they show strong pass positivity with lack of Alcian blue staining. So other causes of past positivity could be fungal infections, but they'll be positive on the Alcian blue as well. Whereas in PAP it would be negative. So this kind of ball, makes you think that probably it is alveolar proteinosis. And the test of choice to confirm the autoimmune PAP is anti-GM-CSF antibody, and unfortunately, this test is not available in the country. Most of the cases, we send it to US, we just courier it, and they do it complimentary. Once you write a mail to us and they agree, they don't charge you anything. You just need to pay for the courier charges, and the turnaround time is usually 3 to 4 weeks. So you might have to wait to diagnose whether it is autoimmune or secondary. So if this report comes back positive, the benefit is that a biopsy can be avoided. So this is a very important step in the diagnosis of primary or autoimmune PAP, and the sensitivity is as high as 100%, and it is quite specific as well. So the levels can also be done in the bowel fluid, but we don't have any experience on that. We usually send the serum autoantibodies, and studies have shown that the bowel levels, they correlate better with the PAP severity, and the serial levels may prove useful. But in practicality, it is not possible because every time you're sending the sample abroad with a turnaround time of 4 to 6 weeks, usually the management cannot wait. Now, once you've diagnosed it with the autoantibody and positive radiology as well as a milky bowel, you might need a biopsy if you don't have a autoimmune panel which is available where the positive antibody is not there. So in that case, a biopsy may be required. But if the patient is hypoxic, then the risk of biopsy is quite high. So when you come to whole lung lavage in primary PAP, every patient presenting to you with pulmonary alveolar proteinosis might not need a whole lung lavage. This is being a rare disease, there are not any randomized controlled trials, but what we have is this very lucid article by Campo, which was published in 2016, a decade ago, but it still holds good, which is a multi center survey of approximately 20 centers, and that looked at the indications. So most important indication is a decline in lung function. So if you have a patient who's symptomatic, who's progressing, who's got worsening oxygenation, increasing opacities on radiology, and worsening lung function. So these are the other criteria which have been looked at, which is decline in resting saturation, worsening radiology, decline in DLCO, FVC, as well as decline in SpO2. And symptom-based therapy is done only in 42% of the patients. So you have to look at, comprehensively, not only at the symptoms, but also at the radiology, the lung function, as well as the progressive decline in these. So you need to many times watch these patients over a period of time to see whether they need whole lung lavage in case they deteriorate. So when do we do whole lung lavage? So this is again from a survey done from various centers. So when you look at the resting saturation, PO2, if it is less than 65 with a high alveolar arterial gradient on ABG, which is more than 40 millimeter mercury at rest, and the patient is symptomatic with severe dyspnea and desaturates at rest or on exercise. So it is a composite of symptom, the ABG, as well as the blood gas, the alveolar arterial gradient, and there should not be any absolute contraindications. So again, the contraindications have been extrapolated from the contraindications for bronchoscopy, where if the patient has coagulopathy and if the INR is more than 1.5, platelet is less than 50,000, one would be wary to do a whole lung lavage. And also there should be no hemodynamic instability and recent, MI within the past 4 weeks, because then these patients are very unstable to undergo a massive procedure like a whole lung lavage. Also to note is that there should not be any active bacterial infections, because these patients have got a poor immunity because of the delayed surfactant clearance from the alveolar macrophage. So they have got macrophage dysfunction and they are prone to host of infections with atypical organisms. So you need to treat the infection first and thereafter probably look at the whole lung lavage. So active bacterial infection is the absolute contraindication in these patients. So if you look at the journey of these patients, so once you have diagnosed primary PAP, you look for the autoimmune panel, which is anti-GM-CSF antibody. If it is positive, it confirms autoimmune or primary PAP. Then you look at the symptom burden. If they are symptomatic with a PO2 less than 65 on room air and alveolar arterial gradient more than 40 in these patients, then you subject them to lung lavage. If they are stable, they are not hypoxic, then you can probably observe them over a period of time. And if they were to progress, then offer them lung lavage. Similarly, post lung lavage also, you follow these patients in terms of their radiology, the oxygenation, as well as their lung function. And in case they deteriorate, then they may be offered a repeat whole lung lavage as well, which I would be discussing in my case. So this is a flow chart. Now coming to the technical aspects. So, as I've mentioned, because of rarity, most of the data is based upon case series and multi-center experience, and the procedure has not been standardized. So pre-procedure, what you essentially need is a full pulmonary function test, especially on a body box where you have the lung volumes, you have the FRC. So determination of FRC is very important in these patients because that helps you in calculating the amount of lavage fluid which would be instilled. So once you get the FRC, you plan the lavage volume based upon that and which side to lavage. So it's a bilateral disease and the patient needs a, maybe a sequential or a simultaneous lavage. But when you are most commonly in most of the centers, a sequential lavage is done where the more diseased lung is washed first because the less diseased lung is easier to ventilate. So you identify based upon the imaging, the side which appears worse on a HRCT should be lavage first, And if it is like a symmetric disease bilateral, then you might have to do a perfusion scan and find out that the side which is less perfused may be the one which is lavage, because a more perfused size will be better and easier to ventilate. And this is more true when the patients come to you late in the disease course and are hypoxemic or on oxygen. So they may not tolerate a single lung ventilation. So ventilating would be easier for a better lung. So that is why you need to decide which lung to do first. And you also need to prepare, warm saline, and that can be done with the help of blood warmers, which are there in the ICU in most of the places, or in the OT. You have to warm it to 37 degrees before you start, instilling it. And a very important thing is that you use a Y adapter, which I'll be showing that. So there will be an inflow lead in a WM tube and a efflux lead. And also the place where this bag is placed, it should be 50 centimeter. If you keep it very high, the fluid is going to come with a gush, and there is a higher chance of barotrauma in these patients. So you measure half a meter above the mid axillary line, and that is where you hang these bags. And it is a gravity dependent, insufflation of the lung. So coming to the timing of whole lung lavage, as I've mentioned that usually these patients present very late, and more so in our country where they're treated for various infections before coming to us. So in this study from Seymour from US, the median time from diagnosis in these series of 92 cases of PAP to whole lung lavage was 2 months, and majority in 80% of the patients, the whole lung lavage was done within 12 months. So that is what is there in West, but in our cases, the delay might be even more longer. So by the time they come to interventional pulmonology center, they are usually hypoxemic and they are on oxygen, and they have repeated multiple courses of oxygen and many times steroids, as I would be discussing in our case. So what would be the anesthetic and the personal requirement for whole lung lavage? So this procedure is done under GA in OT. And since there'll a lot of ventilation inhomogeneity as you'll be lavaging one lung. So rather than inhalation agents, a combination of IV propofol along with opiate and a neuromuscular blocker is required to keep these patients relaxed so that they don't buck on a single lung ventilation. So you need a whole village actually to do a whole lung lavage, and the team comprises of interventional pulmonologist, anesthetist, respiratory technician, physiotherapist. And if you're planning to do it on ECMO, then the number of people helping you out is much more. You also need a perfusionist, an intensivist who's explained, who's trained in ECMO. And most of our procedures are done with the help of the cardiac anesthetist in the OT. So most of the time is done in OT, but we can also do it in ICU if the patient is on ECMO and there are issues with shifting the patient on ECMO. So what are the steps? The most important step is the placement of a WM tube. As you're aware that the WM tube is of two types. It can be a left WM tube or a right DLT. So in most of the centers and also in our center, we exclusively use the left DLT. The reason is that if you use a right DLT, the orifice to ventilate the right upper lobe may get blocked in case there is a malpositioning of the tube, which happens when you shift the patient, because you have to shift the patient in lateral position when you are percussing these patients. You are doing a Trendelenburg or reverse Trendelenburg position. If the tube moves, then the right upper lobe may get blocked, and that might affect the ventilation as well. So what you do is you put the DLT in the left main bronchus, and there you inflate the bronchial cuff. As you can see in this WM tube, the blue is the bronchial cuff, which inflates, it goes into the left main bronchus, and the tracheal cuff is present in the tracheal lumen. So most important procedural step before you start instilling saline is to make sure that your tube position is right. And that is confirmed with the help of bronchoscopy. And when you have put a double lumen tube, the lumen size is much less. So adult bronchoscope cannot be inserted in that. So as you can see, we use either a pediatric or ultra thin bronchoscope or these intubatic bronchoscope, as you can see in the picture, to confirm the tube position. And this is what you should see. So this is the bronchial tube. So you have entered through the tracheal lumen. You're looking at the carina, and as you can see here is the inflated cuff of the bronchial tube, which is the bronchial cuff in the left main bronchus. So this should ideally be at least 2 centimeter distal to the carina, because even if it moves, there will be no leakage around the tube. And this is the uncuffed part of the tube. So once you have inserted, you do a bronchoscopy to confirm the tube position. And once you have confirmed the tube position, you must ventilate one lung and check for a contralateral leak. So this can be done with the help of instilling, the other side, which is non-ventilated, putting in a catheter, and you look for the bubble in the saline cup. As you can see here, after this over here, the bronchial tube in the left side is being ventilated, and the right is a non-ventilated side, so there should be no leak. If it is a good seal, then there'll be no leak of air seen in the right side. So you do it for once for the left side, and then you do it for the other side. So you have to confirm both the sides with the basically leak test. So in case there's a leak, the problem is that when you start instilling saline for doing whole lung lavage, the contralateral lung will also get flooded. So I hope I'm clear that we use a left DLT, confirm the tube position bronchoscopically, and thereafter we also look for leak on both the by ventilating one lung and then looking at it in the non-ventilated lung into a saline-filled water cup, as you can see in this image. Now, the position, this is a topic of debate, and the position varies from center to center, and various positions like supine, moderate lateral, complete lateral, prone, a lot of positions have been described. So every position has got a advantage and a disadvantage. So when you do supine, actually, some of the centers do it supine if they are doing a whole lung lavage on ECMO and you're doing a sequential whole lung lavage, because shifting sides on a ECMO becomes difficult, especially with the cannula. But when you're doing it with a double lumen tube, what is most commonly followed is that you ventilate the dependent lung, and as in this case you lavage the superior or the non-dependent lung, because that is amenable for percussion. And the other advantage is that the VQ mismatch is much less when you are putting the ventilated lung lower, so there the perfusion is going to be higher and the ventilation also is going to go there, so the oxygenation is much better and well maintained during the procedure. And if lavage the lung which is inferior, then there is more desaturation. But the only flip side is that when you are lavaging a superior lung, there may be aspiration in the inferior lung on the contralateral side. So these are various, there is nothing which is right or wrong. It depends upon the center's experience. So what we most common do is when you're putting a DLT, we ventilate the dependent lung and we percuss the non-dependent lung, as you can see in this image over here. So the next step is how you determine the volume of saline to be instilled. As I mentioned, there is no standard guideline. You have to do full PFT and you find out the FRC. So right lung, the FRC is 3/5, and for the left it is 2/5. And if the TLC is less than 2.5 liter, then the rule of thumb is you don't give more than aliquots of more than 750 ml of saline. And usually you start with 750 ml, increase it to 1 liter, and see if there is aspiration on the other side. So most centers use 750 ml to a liter when you're doing a whole lung lavage. So this is how it is done. So after putting the patient in the lateral position, after confirming the tube position, so this is the blue is the bronchial cuff, the tracheal cuff. So the Y adapter is here. So after you instill from one side into the double lumen tube, the other side is clamped, and you put the fluid from one side and it comes out from the other side. And you can see here that the milky whole lung lavage fluid is coming down and it is collected into the container. So as I've mentioned, the steps of the procedure is that the most severely affected lung is lavage initially. Initially, you ventilate for 15 minutes with 100% oxygen for denitrogenation. Thereafter, you degas and start slowly filling the lung at a rate not exceeding 125 ml per minute. So if it is a very rapid insufflation, installation of fluid, there may be barotrauma. So that's why you should not go faster. So if you're putting 500 ml, it should be within 4 to 5 minutes. So 1 liter normally the time to put the fluid in should be 8 to 10 minutes. And thereafter we start doing the percussion and then allow the saline to flow under gravity into the lung up to the estimated FRC. And thereafter we do some percussion either manually or mechanically, and after that we open the drainage to the outlet or towards the efflux, and the milky fluid or the fluid with a lot of surfactant material flows out. And you also need to continuously monitor the lavage output and input in these patients and continue until the effluent is clear, and actively suctioning the remaining fluid from the lung. So this is how it is done, as you can see here in the video. So this is the fluid has gone in, the percussion is going on, and as we open, you'll find that the effluent is coming out, which is milky. This is a gravity dependent drainage. And the end point is, as you can see, initially there is a lot of sediment in the bottle marked 1, and over a period of time, after you have done aliquots of 1 liter, so the sediment keeps reducing, and you keep doing it till the end point, which is a clear effluent in these patients. So you have to maintain the chart of the amount of fluid every cycle, the volume instilled, the volume drained, and the retained volume. What is the positive balance, like you do for a peritoneal dialysis? What is the cumulative balance, whether the FRC has been reached? What is the color of the effluent? because it is very important to look at the large losses, because if there's a large loss of fluid, it may indicate either a loss into the pleural space leading to pleural effusion, or a contralateral leakage, which can, in the single lung ventilation, it can cause flooding of the single lung. So that is why you have to monitor these losses with every cycle. And the monitoring is very important of oxygen saturation. And physiologically, you see that as you keep instilling fluid, the highest saturation is achieved during the completion of the filling phase. And this is because of blood physiologically being shunted from the non-ventilated to the ventilated lung, that is the dependent lung in our case. And conversely, when you drain the fluid, the oxygen level starts to drop because of the physiological changes. You need to do serial ABGs. So bispectral index is done for the level of consciousness, and also hemodynamic monitoring is required because there are physiological alterations in blood pressure during lavage due to variation in the airway pressure. So this study looked at the cerebral monitoring of these patients, and this is from my friend cardiac anesthetist Colonel Bhargav, and it was published in way back in the British Journal of Anesthesia, where they saw that there was significant decrease of cerebral oxygen saturation during single lung ventilation measured during absolute oximetry, as you can see. So this is one lung ventilation, whole lung lavage during the OT, during the single lung ventilation. So that is a very sensitive index which can be used in monitoring these patients. So at the termination of the procedure, once you have completed the procedure, the residual saline is aspirated, you do suction. Thereafter, you ventilate with 100% oxygen. The DLT on table is replaced with a single lumen endotracheal tube, which has got a larger lumen, doesn't get clogged, and it is easier to do suction in that. And also a bronchoscopy is done to aspirate the residual fluid. And you may like to give, if the positive balance is there, you might like to give some diuretics and PEEP to clear the lung from the fluid. And the patient is monitored in the recovery unit on mechanical ventilation, where a chest x-ray is done post procedure to rule out complications. And if there's no pneumothorax and there's good clearance, then one can, and the patient is stable, then one can probably extubate the patient. And this is the radiology which is done immediately after the procedure, and you find that the clearance is immediate. So radiological response, as you can see in the right sided whole lung lavage, is complete clearance post procedure immediately. So this is our experience, which is a multi-center experience. So this is published around 5 years back. We had done this analysis of 10 cases where a median whole lung lavage of 23.5 liters was required per patient, and the highest cumulative volume was 35 liter. All the patients showed significant improvement, and none of the patients required more than one session of whole lung lavage per lung. What we have seen over the years is that with improving anesthesia support, longer lavage times, larger amount of lavage fluid, and experience increasing this field, more patients remain symptom free and recurrence free at 3 years. So 70% of the patients followed beyond 3 years remain free of recurrent PAP manifestations, compared to what it was done in 20 years back, where lesser lavage volume and shorter times were used for these patients. The second patient, again a case of hypothyroidism, diabetes, and hypertension, presented initially to another hospital with dry cough and progressive breathlessness of 6 months duration, was hypoxemic, tachycardia, tachypneic, and bilateral crackles were there, and patient system examination was normal. This was X-ray and the CT showing crazy paving. The patient was diagnosed as NSIP, initially treated with steroids and then sent to a center. And on tapering dose of steroids, she was in domiciliary oxygen. However, she had progressive increase in oxygen requirement. And the bronchoscopy, high risk bronchoscopy on oxygen, which was done, showed milky bile, which was positive for PAS, and all the other stains were negative, and PCP stain was also negative. So this patient was taken up for whole lung lavage with you know, uh, double lumen tube DLT. Left lung was isolated, and patient was put in a recumbent position. Vitals were stable, leak check was passed, and the whole lung lavage started on the right lung. And initially, 1 liter of normal saline was instilled. Thereafter, the patient started desaturating, and the saturations dropped to 45% despite being on 100% oxygen. And ABG showed hypercapnia, hypoxia, which did not improve. So the procedure was aborted. This was the first aliquot which was drained, and it was thick white fluid, and 400 ml of milky white fluid was drained. Patient was shifted to ICU and extubated to HFNC after stabilization. The patient did not tolerate single lung ventilation, as now planned for whole lung lavage on ECMO support, which was done the next day. As you can see, intubation. So this is the leak test which has been done, and following venovenous ECMO convolution, and 2 units of blood were transfused. You can see some bubbles. So we've checked the seal, and thereafter we start doing the procedure in these patients. So this was the procedure which was done in the ICU on ECMO support. As you can see, the ECMO machine. So the superficial lung is being percussed. The ventilation on one side, ECMO is on the other side, and we did a sequential whole lung lavage, initially of one lung and then the other lung, and the ABG remained normal. So the patient tolerated the procedure well. And this was the right lung, which was washed with 11 liters of fluid. We do the protein at baseline as well as the LDH, which shows significant improvement post procedure. It reduced from 2 to 1 and LDH from 1600 to 116. Thereafter, the procedure was repeated with 10 liters on the other side, and you can see the clearance. So this procedure lasted approximately 8 to 9 hours. Thereafter, the patient was extubated and a bronchoscopy was done to suck out the fluid. And as you can see here, there's significant clearance. And following which the patient was extubated to HFNC, and thereafter was on nasal prong on day 2, and thereafter the ECMO was decannulated on second day. So, we most of the times do a manual percussion, but that leads to a lot of chest wall soreness, and it is quite tiring, especially if you're doing the procedure for 8 to 9 hours. So, if you have the mechanical vest or the high frequency chest wall oscillation device, they offer more homogeneous kind of percussion, and they can be easily used in these patients, and they better remove the surfactant compared to the manual chest wall percussion. So, studies have shown that studies where a percussion or a mechanical vest is used, the removal of surfactant is much better in these patients compared to where no percussion is used. So once you extubate, so this was a paper which looked at high flow nasal cannula, because these patients have chunky phlegm, and if you put them on NIV, they're not able to expectorate, which can lead to mucus plugging and collapse. So high flow nasal cannula is actually helpful in these patients in humidification of the secretion, it aids physiotherapy, and there's less mucus plugging. So that can be used post extubation as compared to non-invasive ventilation. So to summarize, ladies and gentlemen, whole lung lavage is the treatment of choice for primary autoimmune pulmonary alveolar proteinosis, apart from other rarer indications. So this disease is beautiful, and beyond its rarity, it exemplifies the beauty of modern medicine, where the recognition of radiologic curiosity in the form of crazy paving led to the discovery of a specific autoantibody, and finally to a targeted therapy in the form of whole lung lavage. So it stands as a symbol of translational triumph, a mastery unmasked through science and perseverance. Though we don't have any kind of novel international guidelines, we need to have some for a country. Thank you for the patient hearing. Greetings from Army Hospital Aranda. Jai Hind.
Wonderful, Dr. Vikas. This was like absolutely state of the art talk. You have covered in just 20 to 25 minutes everything that anybody will ever want to know about whole lung lavage, extremely elaborately. And I would just say it was a brilliant talk. And I kind of felt that a person also who had never done a WLL before could actually just pick it up and do it tomorrow. So fantastic.
Thank you.
I'd now like to introduce my very, very accomplished and very, very bright and very distinguished faculty who are my panelists. So first, I'd like to introduce Dr. Santa Kumar. So Dr. Santa Kumar again requires no introduction whatsoever. A fantastic interventional pulmonologist. He's at the Kovai Medical Center and Hospital Coimbatore. And he is an extremely accomplished person who's got so many fellowships. He's a member of so many international societies, so many awards, so many publications. And most importantly, he's running this fantastic IP fellowship where he trains 3 students every year and absolutely makes sure that they are the best churned out interventional pulmonologists who come out from the country. And we are so very happy that his fellowship is associated with IIB fellowship. So a warm welcome to you, Dr. Santa Kumar. We are indeed very, very honored to have you with us.
Thank you, madam. Yeah.
After this, I'd like to invite our very own Dr. Swami Pawar, absolutely brilliant interventional pulmonologist who really keeps a low profile. He always lets his work talk for himself. Brilliant hands, amazing brains, but always very, very quiet and silent. But he keeps on contributing in his very special way. He is the consultant pulmonologist at the Tunga Hospital, Malad, Mumbai. And we are just so proud that he's a very, very important part of our team Mumbai. And every time there's a bad ICU, bad IP procedure, we always want to run to him. Welcome, Dr. Swami.
Thank you. Thank you very much, madam, for the kind words. Thank you.
Yeah. I'm very, very proud and very, very happy to introduce this brilliant pulmonologist, Dr. Mansi Gupta. Again, she requires no introduction. She is the additional professor at Department of Pulmonary Medicine at the SGPGI Lucknow. So many awards, awarded the best DM fellow, got the gold medal, and experience of 14 years, more than 60 publications, book chapters, and fantastic hand at IP, but again keeps a very, very low profile. She again lets her work talk for herself. A brilliant girl, always smiling, and we are always so happy to have her around us. A warm welcome, Dr. Vansi.
Thank you, ma'am. Thank you so much.
Yeah, and now I'd like to introduce Dr. Anand Vijay, again, a fantastic young interventional pulmonologist. He is the consultant at Rajgiri Hospital, Kochi, and he loves interventions with fantastic hands. And he's got so many awards. The very, very famous and coveted Dheeraj Gupta Young Investigator Award during BronchoCon 2023. He got the J.C. Kothari Young Scientist Award. And he also was a state level NCCP quiz winner. So, the best awards, whether it is ICS, IIBU, NCCP, he's got them all. And he is running a fantastic IP fellowship at Kochi Hospital again. And I be so proud to be associated with this fellowship. So, warm welcome, Dr. Anand.
Thank you, ma'am.
Yes, so I'm actually feeling extremely proud and very, very honored that I've got the most accomplished and brilliant interventional pulmonologist with me today. And therefore, the panel discussion today is going to be extremely exciting and interesting. So now let's just start with the panel discussion. I'd like to come first to our speaker, Dr. Vikas. So, of course, you already told us everything, but just for the benefit of people who might have joined a little later, so can you please tell us what are the indications of whole lung lavage? And what are absolute and relative contraindications of whole lung lavage?
So thank you, ma'am, for that question. So if you look at the indications, so the most common indication worldwide would be primary autoimmune pulmonary alveolar proteinosis. And it's a rare condition, but again, whole lung lavage is a procedure which is not very commonly done, but most of the times it is done for pulmonary alveolar proteinosis. Apart from that, as I'd shown, there are case report data where it has been used for the accidental inhalation of lipids, lipoid pneumonias, and also for rarely for alveolar microlithiasis. And in a non-ILD setting, it may be used in patients who got excessive mucus plugging to remove those in cystic fibrosis, and also as an adjunct in for diffuse alveolar hemorrhage, which is refractory to medical management and after giving them plex. So these are the most common indications, and most common being pulmonary alveolar proteinosis, as I have reiterated before. And coming to the contraindications, so most important contraindication, so there is no RCT data, but what we know is we have extrapolated it from the ACCP guidelines for bronchoscopy that do not do a whole lung lavage if the patient has got coagulopathy. That means if the INR is more than 1.5, platelet is less than 50,000, because they're likely to bleed, and more so when you are doing that, manual percussion. So that can be traumatic for the patient, and it can lead to a alveolar hemorrhage and a bleed. So in the setting of uncorrected coagulopathy, don't attempt whole lung lavage. And also for patients who got an active ongoing infection, because when you are lavaging the fluid, that might lead to systemic spread of the infection with the fluid which you are putting in. So treat for the secondary infection first before you start doing. And these patients have got secondary infection because of alveolar macrophage dysfunction. They may have tuberculosis, they may have pneumonia, they may have nocardia, PCP, host of infections which these patients have with atypical organisms. So treat those first before you plan to do a whole lung lavage. And also patients who had recent MI in the last 4 to 6 weeks, they are usually on dual antiplatelets. They are also at a risk of bleeding. So let them stabilize, wait for 4 to 6 weeks, and then you should attempt whole lung lavage. So these would be the most important contraindications. And aspirin can continue. So a lot of these patients are on aspirin. That doesn't cause much of a problem. Though now there is evidence, as in the cases which I showed, that you can do whole lung lavage on anticoagulation, but it should be done in experienced setting, because we have to give anticoagulation when you have to maintain the patency of the cannulas. So in that setting, you can do this procedure as a high risk procedure on anticoagulation. But if you're starting, avoid doing in patients who have got coagulopathy.
Wonderful. So as we know, pulmonary proteinosis is the most commonly said complication, but apart from this, lipopneumonia, silicosis, silicoproteinosis, alveolar microlithiasis also, and accidental inhalation of dust, etc. Also, WLL could help. And as Dr. Vikas rightly said, contraindications are similar to simple bronchoscopy. However, now even on ECMO we are doing WLL, but of course on inexperienced centers. So thank you for that complete answer. Dr. Vikas, another question to you. What specific equipment is essential for a safe and effective whole lung lavage, and why? If you can tell us the role of every equipment.
Great. So what you have to have a center which is experienced in doing it. You have to have a experienced anesthetist, because here the role of, so it's a team. That's what I told you. You need a village to do whole lung lavage. You have to have a good cardiac anesthesia backup, somebody who's expert in putting double lumen tubes. Because if the double lumen tube is malpositioned, it will lead to aspiration of the fluid in the single ventilated lung, which can be catastrophic. And many times the fluid is coming out. You do a bronchoscopy, keep sucking, you're not able to see the cuff, so that can be catastrophic. So before you're starting doing a procedure, you should have a good team where you have a cardiac anesthetist expert in putting a double lumen tube, and you should be able to confirm the tube position. That is very important, because tube position can change when you shift the patient, especially when you make them left lateral, right lateral, all these maneuvers, Trendelenburg, reverse Trendelenburg, when you do during the drainage. So the placement of tube has to be immaculate. So for that, you need a double lumen tube of all these sizes, and especially left-sided double lumen tube, as I've mentioned, because there's a problem with cuff displacement when you're using a right-sided DLT. Then you should have pediatric bronchoscope, because the lumen of especially the 35-37, the DLT, the lumen is very narrow. Your adult bronchoscope does not go in. You have to put either an intubating bronchoscope, or you have to use a disposable bronchoscope. We are using the disposable ambuscopes nowadays, the pediatric ones, to basically confirm the position of the tube in these patients. Apart from that, as I have showed, that you should have a Y adapter, which is easily available in most of the operating rooms, and you can use that, the circuit where there is a tube which is helping to go into the Y adapter, and then it is coming out. Many times you can use the PD circuit as well, the one which is used for peritoneal dialysis, because in that also you are instilling from one end and the effluent is coming out from the other end. So that cannula can also be used if you do not have a Y adapter in your center. So that would be the bare minimum which you should have. In addition, you have to have the blood warmer, because this saline has to be warmed to the body temperature is 37 degrees. So that also has to be there. So I think this is the importance. So that is the bare minimum you should have. Apart from that, you should have basic monitoring. You should have an NIBP. You should be doing a ECG monitoring. So if your center is good, the level of consciousness you can do with a BIS. And as you are, I've shown that the cerebral, oxygen monitoring also is being done in our center, as I've shown in that slide, especially for patients who are being done on ECMO. And that time, if you're doing it on ECMO, then you also need backup of a perfusionist, because that will continue for a long period of time, and bedside ACT, which the clotting time should be available. So it depends whether you're doing with a DLT or whether you're doing it in an ECMO. So the requirements keep increasing. So initially, I must tell you that do not try patients who are very extremely hypoxic, because patients who are on, say, NRBM 15 liters, they are unlikely to tolerate a double lumen tube. Patient who's just on nasal cannula, you might just get away with a single lung ventilation. But patients who are extremely hypoxic, who had previous lung resection, they are the ones where you'll not be able to get away without an ECMO, as in our second case.
Wonderful. So we all have to know that whole lung lavage is just not a simple bronchoscopy. We have to make sure that we have an anesthetist who knows how to put the abdomen endotracheal tube. We have a thin bronchoscope to confirm the position of the tube. We need the warmers to heat the saline. We are going to require a vest for physiotherapy for the percussion, and we're going to require the Y connector, and we're going to require a series of monitoring stuff, etc. So please make sure there's a tick mark, a list is met with before you decide to do the do the whole lung lavage. Great. Do you have, Dr. Vikas, 2 more minutes? Should
Yeah,
we do a round of, should we just ask questions to other panelists, or should we finish your question?
yeah. I'll take another two questions, ma'am, if it's because I have to
Okay,
wrap.
great. So basically, because of the Indigo mess, unfortunately, Dr. Vikas, whose flight was in the night, he has to take an earlier flight, so he won't be with us all through. So, Dr. Vikas, thank you for telling us so much in detail everything. I just want to ask you, what is the usual post-procedure care, and what is the expected recovery time? And do most of the patients require post-op ICU, or they are immediately extubated?
Yeah. So I think it's a very good question. So the post procedure, as I've told you, that we monitor these patients in the recovery. So depending upon how bad the lungs were and how much amount of fluid and how long has been the procedure time. So we usually do not do both lungs in one setting when you do a double lumen tube, because you want the wet lung to dry up and the oxygenation to improve, which may take 2 to 3 weeks. So most of the centers do a sequential whole lung lavage, initially unilateral, wait for another 2 to 3 weeks, and then do the other lung, so that when you're ventilating a drier lung, it becomes much easier. So what is mentioned in some of the literature is that you extubate them on table. We change the double lumen tube to a single lumen tube on table, but we do not extubate them. So they are kept on mechanical ventilation, given some amount of PEEP, and we do a chest x-ray to rule out any complications, and then maybe like to give some diuretics to see that the oxidation has improved. So we give them 4 to 6 hours of ventilation, do the x-ray, do the ultrasound, and see that the fluid has been completely expelled. If not, if they have a collapse, if they have a pneumothorax, pleural effusion, do ultrasound and try to drain that, and also like to do a bronchoscopy if there's a lot of mucus plugging inside. So that all has to be done on a case by case basis. But in most of our patients, because coming to us in a quaternary center, they are quite sick, they are hypoxic, their oxygen requirements are high, so we are not able to extubate them on table, and we usually keep them in ICU overnight. May like to give them 4 to 6 hours of ventilation, and if they do well, then we extubate them to HFNC as I have showed. Otherwise, continue, especially in the patient who was on ECMO, we continued overnight ventilation, extubated the patient first, and after a couple of days removed the ECMO. So it has to be decided on a case based approach, and depending on the findings which you get on the x-ray and the ultrasound and the blood gases as the patient gets better.
Wonderful. So one last question for you. What is the role of ultrasound during whole lung lavage? Do you recommend it to be done regularly, or you would do it if
So,
you're
that's,
expecting a
I think it's a good
complication?
question. And nowadays, with the advent of ultrasound, it's very handy. So, we also tried in some of the cases when we were instilling fluid, we saw that the B lines increase when we are instilling fluid, because it is a iatrogenic pulmonary edema, it is a iatrogenic flooding of the lungs. So the B lines got more, and as we remove the fluid, the lung got drier, the B lines reduced, and it's very helpful to monitor for complications, because if you're finding that suddenly you have lost 1 to 1.5 liter of fluid, so possibly it has gone to the contralateral lung, or it might have seeped into the pleura. So in that case, ultrasound is very helpful to look for pleural effusion, and also it is helpful for ruling out pneumothorax. As I've told you that you instill the fluid very rapidly, or if you keep the bottle very high, the fluid comes in with a gush, and these are the lungs which are fibrosed, and they are the ILD lungs which do not tolerate large amount of volume and may lead to pneumothorax in these patients. So that is also helpful, because so it should be a controlled amount of inflow of fluid in these patients. And certainly if you find that there is desaturation, you might like to do a bedside ultrasound to see whether there's a pneumothorax. So it's really helpful on all these patients.
Yeah, wonderful. We're really grateful to you that though you had to basically take an earlier flight, you basically still made it a point to join the webinar because you were committed, and we absolutely thought that the talk was fabulous. And
Thank
thank you
you.
so much for being with us.
Thanks a lot for the opportunity and being with all of you. Thank you.
Great. Okay, so after this fantastic talk by Dr. Vikas, we have our panelists who are going to really tell us everything that we need to know, whether it is whole lung lavage or bronchoscopy in ICU. And I'm really looking forward to listening to each of them. So I'd like to come to Dr. Santha first. So, what specific clinical or physiological parameters guide the decision whether we should do whole lung lavage or not? And what is the recommended management for patients who are on anticoagulation or antiplatelet therapy prior to WLL?
So thank you for the question. And yes, Dr. Vikas Mama was telling in this talk, and we all should understand that as soon as the patient is diagnosed to have pulmonary alveolar proteinosis, we need not jump and do it whole lung lavage in all patients. So that is very important for the postgraduates. So, as soon as the patient is diagnosed to have pulmonary alveolar proteinosis, we need to look at various parameters. And most of the time, symptoms will drive you to decide on that whether the patient can be taken for whole lung lavage or not. Apart from symptoms, there are more important physiological parameters we should look into. If the patient is having resting hypoxia, the arterial oxygen is less than 65 PaO2, that may be the indication for whole lung lavage if the patient is severely hypoxemic. And you can look at the alveolar arterial oxygen gradient. Normal is around 5 to 10. If it crosses more than 40, then that may be the time where you have to think of whole lung lavage. And if the patient is having significant exercise desaturation, so for example, in 6-minute walk test, he is desaturating below 88, then probably you have to think of whole lung lavage. And despite the parameters, patient is having progressive symptoms or progressive radiological deterioration. All these are the timings where we need to think of whole lung lavage. So the point here is we need not jump and do in all patients who have pulmonary alveolar proteinosis. patients may give you some time, some window time before we think of whole lung lavage. And if we go and jump and do the whole lung lavage in all patients, the benefit of whole lung lavage may not be realized by the patient because it's a very invasive procedure, very cumbersome procedure. We need to do it's a teamwork, and we need to have a backup and all those things. So we have to think twice before doing whole lung lavage. Appropriately indicated patients only we have to do.
Great. And what about patients who are on antiplatelets or
Yeah.
anticoagulation?
So regarding antiplatelet and anticoagulants, there is no specific separate guidelines here. So we follow the ACCP BTS guidelines here as we do for the other patients. So basically, if the patient is on aspirin, we need not stop aspirin and all. We can go ahead. Patient is on clopidogrel for cardiac disease and all, then it need to be stopped at least 5 to 7 days before the procedure. And as far as the warfarin is concerned, that is the vitamin K antagonist, it also need to be stopped before 5 days. And the target INR should be below 1.5. That should be kept in mind. And as far as the other oral anticoagulants concerned, need to be stopped at least 2 days, 48 hours before the procedure. And when the patient is on heparin, then probably if it is a conventional heparin, it's going to be before 6 hours. And if it is a low molecular weight heparin, it is, has to be stopped at least 24 hours before. And once we complete the procedure, we can restart these medicines within 20 to 48 hours as the patient, depending on the patient's bleeding risk and other parameters.
Wonderful. This was such a complete answer. So I just want everybody to know that just because you see crazy paving on HRCT and just because you've got your first pulmonary alveolar proteinosis does not mean you go ahead and do whole lung lavage on the patient. There are actually PREPO criteria. Patients have to be breathless. They have to be hypoxic with PO2 of 65 or 70. The alveolar arterial gradient has to be 40 or more. The PFTs have to be going down. The X-rays or CT scans have to be worsening. Otherwise, you just don't see the CT scan and just do the whole lung lavage. You want to do it when the patient really needs it. So thank you for this great answer, Dr. Santa. I'd like to now come to Dr. Swami. So, Swami, can you please tell us how is the double lumen endotracheal tube place confirmed? And how is it managed to prevent spillage into the contralateral lung? And if at all there is a spillage, then what will tell us, how do you diagnose the spillage and how do you rectify it? Because this is a very, very important part of whole lung lavage, and we have to understand that precautions are better than cure. So then you basically have to just, so can you tell us please, Dr. Swami? Can you unmute yourself? Oh, I think there's some network problems. I think we'll just come.
Is a
Yes, yes.
Yeah, the placement of double lumen tube is a skill job. We definitely require a skilled anesthetist to put the double lumen tube. Once the double lumen tube is placed, as Dr. Vikas has also suggested, you have to confirm it under the vision. So you have to pass a ultra-thin or a pediatric bronchoscope, which normally passes through the tracheal lumen, and you have to confirm the balloon has been inflated completely and there is no leak. Second, you can confirm it manually also by just putting the tracheal arm into the non-ventilated arm or the lung on which you are going to do the lavage, and put it under the saline and check for the bubbles, especially when you ventilate the lung which you are not going to do the lavage. Now, after confirming this, once you start the lavage, it is very important that you monitor the other things because you are going to put large amount of saline into the lung. So hypothermia also you need to monitor very regularly. Yes, there are always chances that there can be spillage because you are going to.
I think we've lost him because of poor network. I think, yeah. Swami, you're muted.
I have a network issue, I think. So you have to actually check for this hypothermia also. and there can be spillage, especially because you are going to change the position of the patient. So you are going to do the percussion in a lateral position, in a 30-degree position. So the tube actually can change and there can be a leakage. So the leakage, there you have to monitor the saturation, you have to monitor arterial blood gases. If you are actually seeing the SpO2 falling or the patient not being ventilated, there you can actually suspect there can be a spillage. Also, as you have mentioned the role of sonography, you can actually do a sonography also, USG also, to confirm that there are any leakages or not. And if at all there are any spillages, then probably you have to reposition the tube. That is the one thing. And you can use the diuretics basically to reduce the pulmonary edema or the fluid which has gone on the other side.
Wonderful. So basically, you require an anesthetist who really knows how to put the tube. You want to use a thin bronchoscope, whether it's disposable, whether it's pediatric, and you want to make sure the tube is in position. And you also want to make sure that the lung, which is not being lavaged, you want to put a catheter and make sure that there's no bubbles coming out. What is really important is while you're doing lavage, if the endotracheal tube of the lung, which is not being lavaged, if you see fluid coming out of the endotracheal tube, then please suspect that spillage has happened in the contralateral lung. And as Dr. Swami said, you can do a bronchoscopy again and you can confirm if the tube is in place and you can adjust it accordingly. And also you can check the pressure of the cuff. So thank you, Dr. Swami, for this very important answer. Great. So now coming to Dr. Mansi. So though Dr. Vikas did tell us, I kind of feel that it'll be really nice if you revise the procedure with us because, for a person who has not seen WLL, it'll be very difficult to really imagine the procedure. So if you can please describe the procedure of whole lung lavage in short, and you describe the procedure that you all prefer to do at your place, and if there are any variations which are done at other places which might help others, then you could add on also.
So in our setting, first thing is same that first you have to confirm whether the patient needs whole lung lavage. The indication should be clearly weighed out. And so we have mild cases to severe cases. Mostly, like sir has already said, that tertiary care centers, they have advanced cases. So second step would be to prepare your team very well. We always have a cardiac anesthetist with us, and ICU team is always, we are part of the ICU team and the intervention pulmonology team. So we always do these procedures in a very planned way. There's an institutional protocol, and I think every institution should have its own local protocol for a WLL so that the whole network will get activated once you plan a procedure. And regarding the procedure per se, there is no doubt that it has to be planned under a DLT setting with one lung ventilation going to happen and a general anesthesia is going to be there. For cases which are admitted in ICU and who are having a PO to FiO2 ratio of less than 150, just like a severe ARDS setting would come to you, in those cases, we always have a ECMO backup planned prior. So that we don't land up into any complication and we are already ready with everything in terms of circuit and everything. And for the patient, there is no standardized way of deciding whether we are going to do a sequential WLL or we are going to do in single setting. It totally depends on how well the patient tolerates the single lung ventilation. So we have done a couple of patients in single day where we could have the stamina to perform both the sessions in the same day after, we took a break of 2 hours and ventilated the patient because the patient was withstanding the procedure very well and we did both the lungs on the same day. But mostly, like sir has said, sequential is always better in terms of, not causing the team exhaustion and also for the patient also. So mostly they are done 3 weeks apart. So prior to that, the second thing on the day of procedure, all the vitals are adequately monitored and you have the typical ICU setting in the OT as well that you have to have. And the person taking control of the ventilation is very important because you have to have a controlled PEEP and a low tidal volume setting, and the patient's single lung has to be adequately ventilated. Much has been said about securing the double lumen tubes, so there is you have to do it the way it has been told earlier. And after that, you have to give saline in a very guarded way. So the amount of fluid that you're going to instill will totally depend on patient's, FRC, expected FRC. In a severe ARDS, it's going to be less. So usually in our setting, we have seen that. So sometimes it's not possible to do a pre-procedure FRC, and mostly it is not done. Patients are quite distinct to perform a test like that. But mostly in our setting also, we have seen that 15 to 20 liters on one side is what we could achieve in most of our patients in one day. And clearly, you are using a very guarded way of instilling the fluid at a particular height. So 30 to 50 centimeters is what we try to keep it. It's very simple to perform when everything is stabilized in terms of hemodynamics. ABG is quite handy at our setting, so we use it to our benefit, because PaO2 and PCO2 are the two important parameters physiologically that you have to keep on monitoring. Second thing is, we instill an aliquots based on patient's tolerance. So initial aliquots can be a little, first aliquot can be 500 ml, and then later on we can actually increase it to 1 liter also, depending on patient tolerance. And it has to be a warmed fluid. Regarding the percussion strategy and the position of the patient, you should remember that patient, whatever patient can tolerate. So it is preferable to do what Sir has said, that the lavage lung should be kept in the non-dependent part, but sometimes we have to do a supine case also. And percussions, we are mostly doing manual percussions, but sometimes if the vest is available and we can, plan it like that, vest would be handy. Once the we quit the procedure, not by any lab parameter, just by the clear fluid when it starts coming and the patient's vitals are stabilized. We would just and we do not extubate the patient right on the table. We would take some time. Transfer the patient on a normal ET tube to our ICU, the double lung ventilation, and then take a couple of hours or maybe 6 hours, and then plan a very planned extubation for the patient. So that's how we do it, ma'am.
Okay, great. Thank you so much for this elaborate answer, which just covered everything. And I just want everybody to know that you have to have a warmer. The saline that you use has to be warmed. It is very, very important. Thank you, Mansi, for this fantastic answer. I'd like to now come to Dr. Anand. So, very important question. I wanted to ask you, what is the optimal position, or what are the different positions that people do WLL in? And what is the optimal interval between two whole lung lavages in the same patient? Like, like same sitting after 1 to 2 days, after 3 weeks. Just elaborate what you think is the best. And after one lavage is done, how frequently will the patients require subsequent lavages? Dr. Anand? I think some network issue. I don't know what's going on. I think while he comes back, maybe I can come to Dr. Santa. Okay. So, Dr. Santa, what are the most common? Yeah, I think he's logged out. He'll just log in again, I think. So, what are the most
Okay.
common complications encountered post procedure, and how to manage post procedure hypoxia?
So as we all know that this is a prolonged procedure. Patient is under general anesthesia, and we are flooding saline inside the lungs for prolonged periods, and the saline is drained. So obviously, the patients, the immediate post-procedure, the expected complication is the hypoxia. So patient will have hypoxias for prolonged periods after the procedure. We need to take care of the hypoxia. Hypoxia is the most common complication. And other rare complications or minor complications can occur. The patient may have a few hours of fever or few days of fever. As Vikas was clearly telling that infections are very common in these patients, so we need to take care of the infections also. And sometimes because of the gushing of the fluid inside, there may be a barotrauma to the lungs, and there may be a leakage of fluid into the pleural cavity. There may be pleural effusions, and sometimes pneumothorax also can happen in these patients. So we need to look for all these complications post-procedure, whether the patient is extubated on table or the patient is being ventilated in the ICU for 24 hours or the patient is on ECMO. So we need to monitor these complications, closely monitor the oxygenation level, look for the infections and look for the pneumothorax and all those things. We need to take care of them appropriately. As far as hypoxia is concerned, so patients should be properly mechanically ventilated for at least few hours post-procedure, and the entire fluid which was instilled in the lung should be cleared. Bronchoscopic assistance may be taken for clearing the residual fluid inside the lung. And during mechanical ventilation, adequate PEEP should be maintained. So to recruit the lungs. So adequate recruitment of the lung post procedure, adequate duration of mechanical ventilation, maybe for 24 hours like that. and X-ray monitoring or ultrasound monitoring, depending on the center's preference, and antibiotics and other supportive medications if needed in case of if you are suspecting infection, all those things. And sometimes the ECMO help also can be taken if the patient is severely hypoxemic, not coming out of the ventilator, if there is a weaning difficulty. If you think, then patient may be taken on ECMO, or the procedure is done on ECMO, then probably ECMO can be left alone, left on the patient for a few more days until the patient improves. And most of the patients will recover within 24 to 48 hours from this if the procedure is uneventful and if everything goes uncomplicated.
Great, wonderful. So I just want everybody to know that all the complications that happen in a simple bronchoscopy are much exaggerated in whole lung lavage. So whether it's hypoxia, whether it's bronchospasm, whether it's pneumothorax, pleural effusion, infections, the chances are much higher, and therefore you have to know, you have to have assisted many WL, whole lung lavages before you plan to do one. Dr. Anand, we lost you. So I'm just coming back again to you, and I'm repeating the question for the benefit of the audience, that what is the optimal position for doing WLL, and what is the interval between sequential WLL that you recommend, and so just elaborate on this. And after WLL is done for a patient, how frequently will the same patient require subsequent WLLs usually? If you can unmute yourself, please.
Sorry, madam. So, basically, coming to the position of the patient, we can either position the patient as supine, or we can actually use the lateral decubitus position, or the supine position with the Trendelenburg and reverse Trendelenburg position in between. Like during the inflow, actually you can make a slight inclination, and during the outflow, you can actually make a slight declination. That modified version also you can use. That positioning and everything actually based on, there is no universal guidelines for all this, so you can actually use your center experience and how the patient tolerates the procedure also. Like the lateral decubitus position, and in that also you can actually place the lavage lung up or down. That both has its own advantage and disadvantage. If the lavage lung is placed up, the ventilation perfusion mismatch won't be there much. But if the lavage lung is placed downwards, the chance of spillage of fluid will be less. So that advantage and disadvantage is there for both the positions. So that positioning and everything has to be a decision has to be made based on the patient condition, and if the procedure is done on ECMO support, the best will be the supine position, like that. And coming to the sequential one, again, it also depends on the experience of the position and the condition of the patient. If the patient is not stable, if patient is sick or a borderline patient, avoid a sequential lavage on the same sitting. Or if patient we are taking the procedure on ECMO support, it is better to do the procedure on the same, the both lung lavage on the same sitting. It depends. Again, the advantages, rapid symptom relief will be there for the same sitting lavage, but the procedure duration will be very long. Maybe around 9 hours, 10 hours procedure, and the everything that logistics has to be there. So another option is you can actually plan the other lung lavage after a 24 or 48 hours. That is also possible. So that also, again, you have to see the tolerability of the patient during the first lung lavage session, and then see the post-procedure complications, how better the patient is after the procedure. All those things has to be taken into consideration. And the best one, I feel the best one will be a weeks apart, like maybe a 3 to 6 weeks time period after the first session to the second session, based on the patient clinical condition. That will be best. And coming to this repeated lavages, usually again it depends on the patient's severity of the disease, progression of the disease. If it is a rapidly progressive disease, again the repeated session may be required in another 6 months to 1 year time period. But again, if it is a stable disease, it can go up to 3 years also. The majority of the patient, maybe 60 to 70% of the patient can actually survive without a repeated session for around some 2 to 3 years. Maybe after that, a repeated session may be required. That depends on the disease, the condition of the patient, the age of the patient, and other factors also.
Wonderful, wonderful for this one great answer. So the thing is that the position, a lot of positions have been recommended. Somehow we prefer supine to begin with, and then at the time of percussion, you can always change the position. If you're changing the position, you have to make sure that the WM tube has not shifted. That is very, very important. Again, honestly, we've not done two lavages, I mean, both the sides on the same day. I kind of think that you might just want to do it only if the patient is from out of town and can't come back again. Otherwise, if the patient is from the same city, we prefer 3 weeks. And if the patient is from out of town, then we prefer maybe 48 hours. So great for this wonderful answer. Thank you so much, Dr. Anand. I'd like to now come to Dr. Swami. So actually, I just want to say that in 1 hour we finished the first part, whole lung lavage, and I'm just so happy that we've stuck to our time. And now the next 1 hour of our webinar is going to be on something which is very, very close to my heart and something which is very, very important. Bronchoscopy in ICU, nobody teaches it, and we normally learn it from complications. So let's talk about it and therefore make sure we don't get any complications. So coming to Dr. Swami, what are the indications for bronchoscopy in an ICU setting? And which patients in ICU would you not want to do a bronchoscopy?
Yes, madam, the most common indication or the easiest indication is difficult intubation. If the ICU registrar is not able to do there are some facial deformities, or there are dentures, or there are some deformities, then yeah, low jawline or something like that. But apart from that, in ICU, most commonly the ventilated or non-ventilated patients, especially on ventilated patients, it is the mucus plug. It is the to diagnose the infections, especially the pneumonias, which are not responding to the conventional therapy. You can do it for ventilator-associated pneumonias. You can do it in an immunocompromised patient, especially to target the therapy and to get the diagnosis. You can do it for placement of or checking the tracheostomy tube, and you can put the tracheostomy tube also. But mostly in a ventilated patient, it is basically to diagnose and in a therapeutic way. If you want to remove the mucus plugs, if there is a bleeding, there are blood clots, you need to remove them, you can do the bronchoscopy in the ICU. The places or the time when I won't like to do the bronchoscopy is the absolute contraindication is the recent MI. Then there is a refractory hypoxia. There are bleeding diasthesias. Then there are cardiogenic arrhythmias, or there are tracheal obstructions. I won't like to do it. There are relative contraindication that there can be like thrombocytopenia or uremia, which can be corrected, or the arrhythmias which can be corrected. Then yes, it can be corrected, and you can go ahead and do the bronchoscopies.
Wonderful. So the thing is in ICU, most important, if it's diagnostic, then what is the organism, especially when the patient can't bring out a sputum, or if it's a nosocomial pneumonia, ventilator-associated pneumonia, of course, to intubate the patient, or to suck out mucus plugs, to control bleeding, to maintain an airway, intubate the patient, see the position, if you want to do a percutaneous tracheostomy. So thank you so much, Dr. Swami, for all the indications. I agree. Contraindications are very, very similar to contraindications to a simple bronchoscopy. I would say that the most important contraindication to ICU and bronchoscopy is an inexperienced bronchoscopist. So if the bronchoscopist is not used to doing scopies, then they should not be doing a scopy in an ICU patient, because they end up getting so many more complications. So thank you, Dr. Swami, for this fantastic answer. Now I'd like to come to Dr. Mansi. How many hours of NBM is required when you want to perform bronchoscopy in a patient who's critically ill? And what monitoring is required? And what are the most dreaded intra-procedure complications in ICU patients who undergo bronchoscopy?
So it depends on the patient's need for the procedure. So urgency of the procedure is something which can, if you talk about how much time we need nilpar oral, I mean, if the procedure is urgent, then probably there is no guideline to actually wait for the nilpar oral thing. But if it's an elective procedure and a planned procedure, then 6 hours is the recommended time for solids, and maybe 2 to 4 hours for clear fluids. If you have time on your hands, so nilpar oral can be allowed. For regarding the second question, which was about, sorry, ma'am, I forgot. Second thing that you wanted to ask.
What monitoring is required?
Monitoring. Okay, yeah. So monitoring is just like a bronchoscopy. ICU is very well equipped. So at least I tell my residents that there are lesser chances of complications when your patients are well monitored. So you have a screen there. So all the parameters which are vital, the continuous ECG monitoring, respiratory rate has to be seen, saturation has to be monitored all times, and blood pressure obviously for all the patients who are critically ill. So all these things are important. And a patient who's on a ventilator, so you should be looking at the ventilatory parameters, also the scalars and other things. How is the patient's tidal volume going? Because sometimes patient's cough starts leaking, so the patient has loss of tidal volume. So all those things need to be monitored. Regarding the complications intra-procedure, when we are doing a patient's bronchoscopy, the most important thing, most important complication which happens is hypoxemia. So any patient we should all of us should know that in a healthy person also, if you put scope inside a person's airway, the loss of PaO2 would be around 10 to 20 millimeters of mercury. And if you do a BAL, that amount could be somewhere around 30 to 20 millimeters of mercury. So that loss of PaO2 is going to be expected. So hypoxemia is going to happen even in simplest bronchoscopy in a healthy patient also. So you have to account for that, how sick your patient in terms of hypoxemia, because that's going to happen anyways. Second thing is hypoxia related events, cardiac events. So hemodynamic instability, particularly bradyarrhythmias, are very common. Patients who are, already cardiac patients, they can develop because of hypoxemia and other things. They can develop hemodynamic instability. So prior, it should be planned that the patients should be having an optimized fluid status, and also you should have handy vasopressors if the patient is already not on any vasopressor. And third important thing is sometimes who are predisposed, these patients, especially of obstructive airway diseases, they may develop post bronchoscopy, bronchospasm. That is another complication that can happen. Many a times there is, when you're doing bronchoscopy in ARDS patients, then there is loss of PEEP during the bronchoscopy. So your hypoxemia and de-recruitment can really be worrisome in certain patients. So you should plan your procedures with that thing in your mind, and try to keep shortest possible procedure times in ICU. Mostly that. And bleeding is something which will happen on pneumothoraces. There are rare complications because not commonly are we doing patients transbronchial biopsies or anything on the most commonly performed procedure is either a surveillance bronchoscopy, or you're doing a lavage mostly in most of the patients apart from intubations. So if you're doing a biopsy or other kind of a procedure which would lead to bleeding, that could be also a complication in bronchoscopy. I think mostly that, yes, ma'am.
Great. I just want to tell everybody that when we do bronchoscopy in a normal patient, the starving is 4 hours. Please note that for an ICU patient, a critically ill patient, NBM has to be 6 hours because they are sick patients and gastric emptying is delayed. And therefore, 6 hours is NBM. If the NBM period is not met, you can actually put a Ryle's tube and suck out everything. This patient is critically ill. He's already hypoxic. You don't want any aspiration happening. And as Dr. Mansi rightly said, the monitoring has to be very, very good. And the intra-procedural complications we are most worried about are hypoxia, bronchospasm, arrhythmia, something which we are very, very worried about, hypotension, circulatory collapse, and hemoptysis. So before doing the bronchoscopy, just make sure that you have every equipment possible to take care of these complications, because while you're doing the bronchoscopy, you're inside and there's a complication, you should be able to manage this, and you have assistants who know how to manage this. So thank you, Mansi, for this great answer. I'd like to now come to Dr. Anand. In an intubated and ventilated patient, what are the prerequisites before performing a bronchoscopy? So what is your checklist before you start the bronchoscopy? What will you look for and what will you adjust and then start the bronchoscopy?
So first thing is consent. that informed consent has to be there. We have to explain the family of the patient regarding the potential complications, and if it is a critically ill patient who is not ventilated later
So
also,
this
that
is
everything
intubated
has to be
ventilated
explained and that
patient.
informed consent.
Dr. Anand, we've asked you specifically
Yeah,
for
ma'am.
ventilated
Like
patients, so understood. Consent is a must. What more? We have many things to go ahead. Yes.
yeah, ma'am. So then again, everything, your equipment and what procedure you are planning, that equipments, tools, whatever required for that particular procedure has to be there, including your mucus extractor, what their assistants, training people, everyone. Then sedation and paralysis of the patient. That is very important because if you are not sedating your patient adequately, that itself can lead to the procedure, intra-procedure complications, and the patient can actually damage your scopus also. That has to be kept in ready. And the ventilator settings, that has to be optimized to the and pre-oxygenate the patient very well with FiO to 100% for at least 5 to 10 minutes prior to the procedure. That has to be there. Then the bronchoscope size, at least 2 millimeter size difference should be there with the ET tube and the bronchoscope. That has to be there. And then if any potential complications, like if you are performing BAL or a biopsy, uh, that but bleeding can happen. So that tools that required to control the bleed, everything has to be kept ready, and the crash cart, the emergency drugs, everything has to be there in hand before starting the procedure.
Great. So wonderful. I'd just like to add a few things. We have to know that we are going through the endotracheal tube, and therefore the bite block has to be there. I mean, basically, not the bite block. I mean, you have to have an airway.
Oh,
Just a oral airway has to be there, because even if you're sedating the patient, if you're paralyzing the patient also, if at all the patient comes out and ends up biting, then your bronchoscope is gone, which is a problem. Also, you have to have a swivel adapter or a catheter mount. And basically, the thing is, endotracheal tube will be connected to the catheter mount or swivel adapter, and through the hole, the bronchoscope will be going in. And this is done to prevent loss of tidal volumes and to prevent hypoxia, hypercapnia. So it is very, very important that you have a swivel adapter or a catheter mount. It is also very, very important that through the opening of the swivel adapter or the catheter mount, a lot of lignocaine has to be placed into the endotracheal tube, because the endotracheal tube is very, very stiff. And when you're going through it, you might just end up damaging your scope. So this is actually very, very important. And otherwise, everything that Dr. Anand told us about, about the sedation, about the consent, etc., and having all the tools. But everybody must know that oral airway is a must and swivel adapter is a must. So great, Dr. Anand. I'd like to now come to Dr. Santa. What are the anatomical and physiological effects of doing bronchoscopy in an intubated patient? I mean, why is doing bronchoscopy in an intubated patient such a big deal as against doing bronchoscopy in a patient who's not intubated?
So, as you told, so intubated patients, the airway is already there, so the tube is there. So when you pass the bronchoscope through the ET tube, you are actually obstructing the airway mechanically by the bronchoscope itself. So there is a mechanical obstruction by the bronchoscope to the airway. So that is the most important anatomical disturbance we are creating into the patient. And because of obstruction, there may be increased the peak airway pressure. And especially when you do a BAL and all, you are going and obstructing a particular segment or subsegment. So you create a regional atelectasis there, and you put a lot of fluid there. So you may create shunting inside the lung. So because there is no ventilation to that particular part, so there is perfusion happening. So the artificial shunting is created. And if you do repeated suctioning during the BAL procedure and all, you may create anatomical injury to the mucosa also. So these are all the anatomical effects which can happen during ICU bronchoscopy. And when it comes to physiological things, as he told, because of the obstruction, there is a transient increase in the peak airway pressure, which may increase the chance of barotrauma. And there may be a transient decrease in the lung compliance also because of the increase in pressure. And especially when you are doing a BAL, you are creating a disturbance in the gas exchange. So gas exchange is affected during bronchoscopy. And the patient is not adequately sedated and taken control on the ventilator, actually it increases the work of breathing for the patient. So patient ventilator dyssynchrony may happen during bronchoscopy. provided if the patient is not adequately sedated and paralyzed. So this is another physiological effect which can happen in the patients. And as far as the cardiopulmonary disturbance or because of the variation in the intrathoracic pressure, there may be stimulation of the vagus, or there may be over sympathetic stimulation, which can create hypotension, tachya and bradycardias, which can sometimes even to lead to transient arrhythmias also. So this is a cardiovascular hemodynamic effect which can happen during bronchoscopy. And there are some systemic effects also. When you do bronchoscopy, you are increasing the intrathoracic pressure and thereby increasing the intracranial pressure also. So you need to be very careful in patients with neurological things, neurological head injuries and all. The bronchoscopy can increase the intracranial pressure. So you need to keep that in mind and during bronchoscopy.
Okay, great. That was wonderful, complete and a lovely answer. So the thing is that we have to understand that when we do bronchoscopy through a trachea, the bronchoscope hardly occupies 15% of the trachea. But in endotracheal tube, it is going to cause more than 50% of blockage. And as a result of that, there'll be increase in airflow resistance. Therefore, there'll be increase in peak airway pressures, reduced tidal volumes. Peak airway pressures can cause barotrauma. It can cause autopeep. Reduced tidal volumes can cause hypoxia, hypercarbia. And the act of doing BAL is going to cause bronchospasm, hypoxia, and blocking of the segments. So we have to be very, very careful because bronchoscopy in an intubated patient is not very simple. And therefore, the time to go in and out has to be minimum. And therefore, the bronchoscopist has to be really experienced. So thank you, Dr. Santa, for this fantastic answer. I'd like to now come to Dr. Swami. So Dr. Santa did tell us about, endotracheal tube and the bronchoscope. So can you tell us a little bit more in detail that what should be the size of endotracheal tube to counter the above effects? Like for example, you want to do a bronchoscopy. So what should be the ideal size of endotracheal tube to counter the side effects of blockage, increased airway resistance, etc.? And if at all your endotracheal tube is small, then what will you do?
You rightly said, madam, because if the endotracheal tube, doing a bronchoscopy in normal trachea and in an intubated patient, you are actually more than 50% of the endotracheal tube you are going to occlude. Most of the adult bronchoscope that we use, which are between 5.5 to 6 millimeter diameter, they can easily go through 7.5 to 8.5 endotracheal tubes. 7.5 will be very tight, but yes, more than 8 they can go very easily. So the adequate or the right sizing of the endotracheal tube is very, very important. In case your endotracheal tube is less than 7.5, then you should ideally adopt to a bronchoscope which is either 4.9 or less than that. And if the endotracheal tube is lesser than that size, then there are pediatric bronchoscope and ultra thin bronchoscopes which are available, which you can use. The flip side of using ultra thin bronchoscope, their channel diameters become shorter and shorter. So getting the secretions out or sucking the secretion out can become very, very difficult, especially clots and thick secretions. You can also try to change the endotracheal tube by if you at all find that the endotracheal tube is of the lesser size, you can actually railroad it when you are actually doing the bronchoscopy. Before just doing the bronchoscopy, you can try to switch the endotracheal tube.
Fantastic, Dr. Swami. So just for the benefit of the audience, I'm repeating it. You have to make sure that the diameter of the endotracheal tube is at least 2 millimeters larger than the outer diameter of your bronchoscope. So usually the adult bronchoscope that we use has outer diameter of 5.7, and therefore your endotracheal tube must be 8 millimeters and more. If it is not, one is like Dr. Swami said, you could use a smaller scope, whether it's intubation scope, pediatric scope, ultra thin scope. I actually don't prefer to do that because, as Dr. Swami rightly said, sucking out secretions becomes difficult. More importantly, the suction is not very good. You end up putting in a lot of BAL, but you end up retrieving very less of it. And as a result of that, the VQ mismatch worsens, bronchospasm is more, and hypoxia is prolonged. As Dr. Swami rightly said, the best would be to put in a stillet and railroad the endotracheal tube and put in a larger endotracheal tube and then do the bronchoscopy. So again, this is so very important the size of the endotracheal tube has to be 2 millimeters larger than the outer diameter of the bronchoscope. Because the usual adult bronchoscope is 5.7, I just want everybody to know the size must be 8. If it is less than 8, best would be to put in a stillet and change to a larger endotracheal tube. For some reason, if the patient is very critical, or for some reason if it can't be done, then you could use a smaller scope. Thank you so much, Dr. Swami, for this fantastic answer. Coming to Dr. Mansi, so we are just going into every small aspect. So some of the questions may be repeated, but it'll be very, very useful for all our listeners to get this really well. So Mansi, coming to you, what should be the changes in the ventilatory settings when you're doing a bronchoscopy in a ventilated patient to minimize complications? So he's on a particular setting doing well. Now, because you want to do a bronchoscopy, what changes in the setting will you do for the procedure?
So we have to understand that, as I said, hypoxemia is the most common complication it is going to happen. So keep your FiO2 to 100% or 1. So that there is no, you get a maximum benefit in terms of time, and try to pre-oxygenate your patient at 100% before you start a procedure at least for 10 to 15 minutes. Second thing is regarding the PEEP strategy. So there are two things about it. We know that when you instill fluid in the lungs, you're going to cause some level of de-recruitment or alveolar flooding. So PEEP would be lost. So in such a patient where PEEP is really important and your oxygenation depends on that, at least maintain that PEEP, and the procedure is only BAL. Then you maintain at that, and sometimes if your hemodynamics allow, you can actually increase the PEEP during the bronchoscopy if you're taking BAL. But if you're doing a biopsy procedure, then obviously your PEEP has to be reduced so that you do not get into the complication of causing a pneumothorax due to positive end expiratory pressure. Regarding the tidal volume, so patients are usually maintained on a low tidal volume strategy, but again, due to the bronchoscope occupying a lot of lumen size, and there will be loss of the tidal ventilation that time. So try to keep at least 6 to 8 ml per kg during the bronchoscopy procedure, unless your patient is an ARDS patient where it's difficult to actually optimize the tidal volume. But in most patients where you can do it, you should keep it at 6 to 8 ml per kg of predicted body weight. Uh, the other thing is what mode to use. Any patient who's on mechanical ventilation, it is important that since we are actually going to have loss of tidal volume due to just bronchoscope occupying the ET tube position, then that time volume control mode is preferred, because at least it will try to deliver and it will take care of the airway pressures. And keep your inspiratory flows high, because again, it's all because of the same thing, that a foreign bronchoscope is going to occupy the lumen, so airway resistance and airway pressures are going to be very high. So that is why you need to keep high inspiratory flow rates, just to counter the airway resistance caused by the bronchoscope, so that you can effectively deliver your ventilation during the procedure time. These are the important things that we should keep in mind.
Great. So as Dr. Mansi rightly said, make your FI to 100%, pre-oxygenate the patient. I would like to make a point over here, which is a little different from what Dr. Mansi said about PEEP. So the thing is that actually speaking, during a bronchoscopy ICU, if the condition allows, you should be making PEEP 0, or you should be reducing the PEEP to minimum, and you should not be increasing PEEP. The funda over here is something very, very mathematical and something very, very scientific. Whenever you have PEEP, the BAL is going to go and sit inside the alveoli, and you will not be able to aspirate it out, and therefore you'll keep on putting more BAL in, and you'll get very little retrieval. So please note, whenever you're doing an ICU scopy, you have to make FI 200, but the PEEP ideally must be made 0. If at all the patient is really bad ERDS, then in that case, oxygenate the patient with 100% for much longer time, and try to reduce the PEEP to as little as possible. But we are not supposed to increase the PEEP during bronchoscopy, because otherwise you'll end up putting in more saline, and therefore you'll cause worse bronchospasm, worse VQ mismatch, and prolonged hypoxia. Then I agree with everything else that Dr. Mansi said. We are going to be using tidal volumes, etc. So little bit of advice: if the patient is on pressure control, then please make the pressure control higher, so that better tidal volumes get delivered during bronchoscopy, because you're blocking the endotracheal tube. So if you increase your pressure control, then the patient will end up getting more tidal volumes, and therefore there'll be less hypoxia, more hypercapnia. If the patient is on volume control, you can definitely increase the tidal volumes that we were supplying to the patient, so that he ends up getting what he was getting. And most important, volume control, increase your peak pressure alarm. We normally keep peak pressure alarms to 45, when you do bronchoscopy alarm, the peak pressure will easily go to 50, and therefore please increase the peak pressure alarm minimum to 50. Otherwise, during bronchoscopy, the alarm will keep on going, the alarm will keep on going, and though you have your team looking at the ventilator, it might make you uncomfortable wanting to look at the ventilator, what is going on. So these are certain things that we would like to do, and these ought to be done when you're doing bronchoscopy in a patient who's ventilated. Thank you, Mansi, for this answer. I'd like to now come to Dr. Anand. What precautions can be taken to prevent pneumothorax if you want to do a transbronchial lung biopsy on a patient who's on mechanical ventilation? So when we were students, we were told patients on mechanical ventilation, TBLB can't happen. No ways. It was a ultimate contraindication. Of course, now times have changed. So if you have to do a TBLB on a mechanically ventilated patients, what can you do to reduce chance of pneumothorax?
So, ma'am, first we have to adjust the ventilator settings like low volume, low tidal volume ventilation is to be done, like less than 5 ml of body weight has to be achieved. Then low PEEP
Why
that
is
can
that
reduce
so?
the
I
incidence
mean,
of
no,
pneumothorax. And
Dr. Anand, what is the connection between
like
5
ma'am,
ml and
ma'am, if
we are not talking
that tidal
about
volume is
ARDS.
less,
We're
actually,
not talking about
that is,
ARDS. We are talking about a very specific thing. ARDS ventilation, I'm not asking.
yeah, ma'am.
I'm asking about on a ventilated patient, you do a TBLB. What will you do to prevent a pneumothorax?
Like the PEEP, actually PEEP, we need to reduce the PEEP, ma'am. If the PEEP
Very
is
good.
reduced, then the incidence of pneumothorax will be, yeah. And again, based on the radiological findings, try to avoid the areas where there are a lot of cysts or areas of bullae, and that areas, if possible, try to avoid such areas. Then like um, immediately after the procedure, you have to screen the patient, like with the help of ultrasound, just check for the incidence of pneumothorax. And after the procedure, a chest X-ray is also recommended after 2 hours to look for any incidence of pneumothorax.
Okay, great. So I'd like to just tell everybody that PEEP must be made zero at the time of taking the biopsy. So the patient is on PEEP, there's no problem when you're doing the bronchoscopy. But when just you're going to take the piece, at that time the PEEP must be made zero. During the procedure, if possible, keep PEEP zero all through to prevent extra distension. That is number one. As far as possible, fluoroscopic guidance is mandatory. And even for non-ICU DBLBs, we always have fluoroscope guidance. But in an ICU bronchoscopy, it becomes very, very important, and you must have this. And I just want everybody to know that when you are going to, like, you basically go in, you open your bronchoscope, you open your forceps, you go in, you catch it. But just when you're going to pull the piece out, at that time, you should disconnect the tube from the ventilator. So when you're taking the piece, at that time, the ventilator is disconnected, and therefore the positive pressure is not there, and therefore the chances of pneumothorax significantly reduce. And this is what must be done in any patient who requires TBLB who's getting ventilated. And of course, you want to have ICD, etc., available to put in if there's a problem. And of course, you want to do an ultrasound, chest X-ray immediately. So again, I want to say PEEP should be zero. You want to disconnect the ventilator just at the time of taking the piece for the fraction of a second. And at the same time, fluoroscopic guidance is a must. Okay, fine, great. I'd like to now come to Dr. Santa. So basically, the thing is that BAL always is supposed to cause hypoxia, but we are never really bothered in normal people. So why is it that BAL causes prolonged hypoxemia in ventilated patients? And patients who are ventilated, in those patients, why is hypoxia prolonged? Because of BAL. And what can be done to prevent this hypoxia?
So, in normal people, the relatively the lung function is okay, and the alveoli, the collapse of the alveoli is not happening there. So the hypoxia may be transient. In ventilated patient also, the hypoxia may be transient, but definitely is more than the normal patients because the entire lung is diseased and you are ventilating the patient for a purpose. And during installation of the ball, it goes and fills the alveolar space, and it compromises the ventilation perfusion. So sorry, the ventilation. So automatically the alveoli gets filled, and you need to even after removing the scope, even after taking the ball out, you will have some remaining fluid inside, and that will take few hours to clear it off. So basically, this creates a problem in the diseased lung. So the lung is normal, then it's a different story. So it creates a problem in the diseased lung. So you will have a prolonged hypoxia. And other thing is in patients with ARDS and all, you're disturbing the circuit by introducing the bronchoscopy. So lung gets de-recruited when you remove the connections and all those things. So automatically the re-recruitment will create a hypoxia, and it will take at least few hours for the ICU physician to regenerate the PEEP and to recruit the lung. So that will be another reason in ARDS patients. And the third reason would be you're introducing the bronchoscope as a mechanical instrument, which will create an obstruction, and the airway pressures are high. And sometimes it may create an auto PEEP also, which increases the dynamic hyperinflation and thereby hypoxia. So these are the basic physiological things which can prolong the hypoxia in these patients. So to take care of these hypoxia, you need to be, as we already discussed, you need to pre-oxygenate the patient very well for at least 10 to 15 minutes before starting the procedure. And specifically, we can use the smaller bronchoscopes with the larger tubes, then the obstruction by the bronchoscope will be little better. So we can avoid prolonged hypoxias, and you be specific in segments and subsegments doing, in doing BAL. So if you take more specific segments and subsegments per BAL, rather than doing a bigger bronchoscope and taking a BAL from the whole, taking a BAL from the whole lobe, you can use small amount of saline rather than doing, rather than putting 100 ml of saline in conventional bronchoscopic valves. So you can use 30 to 40 ml of fluid to extract the ball from the segments, specific segments, more disease segments. It will be more useful in reducing the chance of hypoxia. And of course, the standard ventilator adjustments, keeping the PEEP as required, and precautions during biopsy procedures will definitely reduce the hypoxia.
So very rightly said, a patient who's very sick, even small amount of bile is going to cause hypoxia because of VQ mismatch, is going to give rise to bronchospasm, which is going to be a problem. And a very important part is that every time we do suction, we are actually disrupting the air supply, and therefore lot of tidal volume gets actually lost when we are doing suction. And this also causes hypoxia for a prolonged period. And therefore, you want to make bronchoscopy as short a procedure as possible. Just go in and come out, don't waste time. Put as minimal bile as possible. And also suction time it should be less than 3 seconds at a time. And you should not suck for more than 3 seconds at a time to prevent loss of tidal volumes, which will result in prolonged hypoxia and hypocarbia. So this is for the audience. Our faculty is very nicely giving us all the correct answers. And I'm just trying to sum it up so that you'll get it correct. So quick scopy, minimal bile, and minimum suction period of less than 3 seconds. So thank you, Dr. Santa, for this great answer. So now coming to Dr. Swami, little difficult. So what are the specific considerations for performing bronchoscopy in a patient who's on HFNO and a patient who's on NIV?
So these patients basically, since they are on the, so for the HFNC patients, you have to see to it that the FiO2 is made maximum. The flow should be between 50 to 60 liter per minute. You have to keep the sedation as lowest as possible so that it prevents the respiratory depression. You have to do the procedure really quick. You have to do a very short procedure. You have to use the dental protection to protect your scope. And the patient should be, the position also matters a lot. Probably you have to semi-upright position should be given so that there is a help of the diaphragm also, and the hypoxia is lessened. And you have to be ready, especially since you are going in a patient who is already on a HFNC. You have to be ready with your intubation. For the patient who are on the NIV, nowadays there are special masks which are available, which actually have a special opening on the mask so that it prevents the air pressure loss whenever you are doing the bronchoscopy, and it also protects your bronchoscope. So in NIV patients also, you have to see to it that you are making the FiO2 100%. You have to see to it that your pressures are well maintained. You have to monitor your oxygenation. You have to keep it at more than 90% all the time for both the HFNC and NIV patients. And yes, the sedation should be kept to the minimum. Your procedure should be really, really short.
Great. So very good. So I just want people to know. So frankly speaking, I haven't done a bronchoscopy on HFNO because I kind of get confused where to go from the nose or to go from the mouth. Because there are many studies where they've actually gone through the nose and they've adjusted the bronchoscope along with the HFNO in the nose. I tried, I could not manage. There are so many studies in which they go through the mouth. But over here, the problem is that you have to make sure that the jaw thrust is there and you want to actually close the mouth so that the breathing continues through the nose. So I've not managed to do this. If my patient is on HFNO, I put them on NIV, and then we have this special NIV mask. Through that, we do it. But if you don't have the special NIV mask, there's no problem. The same swivel adapter or the catheter mount that could be connected to a ventilator, the same can be connected to the normal NIV mask, and that can be connected. So the thing is that you need not have the special mask. Through a swivel adapter also can be done. 100% FiO2 and intubation tray next to you are most important. So thank you, Dr. Swami, for this fabulous answer. So Mansi, little difficult question for you. Bronchoscopy via tracheostomy. What are the challenges and pitfalls?
So, tracheostomy, there are two things. First thing, when I always tell my residents, bronchoscopy through tracheostomy is much more difficult because residents sometimes end up damaging the scope a lot of times. And the most deadly complication that we have seen is that the tracheostomy is relatively new. The tract has not really matured, and in that case, they have decannulated the patient, and they're struggling to find an airway, and there's the ET, and you have to intubate the patient. So those are the two important problems with that. But by and large, we have to understand that we are entering the airway through the midway, where the tracheostomy is already there. So you have a short airway length already, and the angulation is very acute. So, you entering the airway and finding your way out is a little difficult. And if the tracheostomy has been there for a long time, sometimes the granulation tissue will form around it, and it is difficult to negotiate the scope around it. It may cause bleeding inside the trachea. So the complications could be a little higher actually than expected. The most important issue is that we should be very sometimes when your patient is just if a patient is with a cuffed tracheostomy tube, the problem of ventilation and other things could be a little bit of the same thing, the degree which we have discussed already with a cuffed ET tube, because the lumen size is going to reduce, and aspiration is not a problem. But for other patient, when your tube is non cuffed, and you're using a fenestrated tube, there could be other problems. You are entering the bronchoscope through a fenestrated tube, probably you're entering the wrong way. So you have to be very careful when you're performing that thing. And aspiration could be a risk in certain patients. You have to be careful because you're in a non-cuffed tube, that could always be a possibility. So empty or NG tube prior to the procedure. But most important that I have already pointed is the angulation that has to be kept in mind. So when negotiating a scope, you have to use a good amount of jelly when you are negotiating a scope, and then do your procedure. Yes,
Great.
ma'am.
Great, great, Mansi, thank you so much. So, Anand, coming to you, you have a patient who was extubated. He developed a stridor. Then you re-intubated the patient, and now your patient is ready to get extubated again. So, does bronchoscope have any role, and how?
Yeah, ma'am. So actually, a bronchoscopic evaluation is required for this patient. So we need to assess whether this any granulation tissue has formed, any subglottic stenosis, any airway wall edema, or any secretions, obstructing secretions are there or not. And so once we got this, we can actually even perform a therapeutic procedure also, like a clearance of secretions and removal of granulation tissue, and even once the patient is stabilized after shifting to a tracheostomy, we can actually go for an interventional procedures like a balloon tracheoplasty for the stenosis as well. So that is required for all these patients, and even the treatment with the steroids and all those decisions are actually based on this bronchoscopy. So bronchoscopy is required.
Great. So, how will you do the bronchoscopy in this patient? Patient is intubated. What will you do?
So we will go to first and we will assess the distal airways and we will see what is happening in the distal airways, and then we will come back. And slowly, if possible, we will extubate and we'll see the trachea and slowly, and we will do the extubation along with the bronchoscopy in the same sitting if possible. And we'll see what is happening in the upper airways and even the vocal cords as well.
Wonderful. So basically, the thing is, as Dr. Anand rightly said, you basically just want to go in and you just want to make sure everything is fine inside. There are no secretions, etc. But what we basically do is that we actually, as we are coming up, we deflate the endotracheal tube cuff. And then what we basically want to do is that you have the endotracheal, you have your bronchoscope just below the tip of the endotracheal tube. And after deflating the endotracheal tube cuff, you start basically withdrawing the endotracheal tube, and with that, the bronchoscope will also keep on getting withdrawn till you see the subglottic area and you make sure there's no subglottic stenosis. Then you'll come to vocal cords and you'll basically just make sure that the vocal cord does not have any edema, does not have any granulation tissue. And you also see the supraglottic region. And after you make sure that there's no reason for the patient to get a stridor anymore and there's no upper airway compromise, only then you come out. And if at all there's a compromise, then anyways your bronchoscope is there. So you pass the endotracheal tube back in and then you want to plan tracheostomy for a patient. So thank you, Dr. Anas. This is very important. When a patient has got reintubated because of stridor, before extubation, doing bronchoscopy to assess the upper airway by deflating the endotracheal tube cuff and seeing everything is very, very important. Great. I'd like to now come to Dr. Santa. So just a minute. By the way, I just would like to let everybody know we have 2,256 logins today, and as of now 2,255 people are still logged in. So I think this is huge, and hats off to our brilliant faculty for the most amazing response. Because of your wonderful presence and the brilliant presence, we've got a huge number of attendance. And what is really important is because of the fantastic information that you all are giving, they all have decided to be around even at 10:20 p.m. So great. Thank you so much. Coming to Dr. Santa, what will you do if a ventilated patient during bronchoscopy develops hypoxia, arrhythmia, or hypotension?
Yeah. So I think if the patient develops significant hypoxia during bronchoscopy, the first step is to remove the bronchoscope, because the bronchoscopy is the reason for hypoxia in these patients, especially
Perfect.
patients who have got fever. So you have to remove the bronchoscope and wait for some time. You may have to do a recruitment maneuver by the ICU physician to to re-recruit the alveoli to gain the oxygenation better. And so if the hypoxia persistence, then probably you have to abandon the procedure, wait for some more time, and repeat the procedure. So that will be the management, and you need to do recruitment maneuvers 100%, give 100% FiO2 for some time, and keep the PEEP a little more and see how the hypoxia is responding. As far as the arrhythmia is concerned, again, if the arrhythmia is induced by the bronchoscope because of the change in the intrathoracic pressures, if you remove the bronchoscope, the arrhythmia is going to revert spontaneously. And if the arrhythmia is persistent, then probably you have to use antiarrhythmic medications, or you have to use the DC defibrillator also sometimes. And for the hypotension, basically, because of the intrathoracic pressure changes, there may be hypotension which is transient during bronchoscopy. So if you stop the procedure and remove the bronchoscope out, then probably the hypotension may improve. You may have to use some crystalloids or colloids to improve the volume status of the patient, provided the patient is not volume overloaded. And sometimes you may have to use the inotropes also to improve the hypotension.
Wonderful. I really loved your answer because the first line you said was the best thing to do. Whenever there's a complication, just come out. Don't think I'll take only 1 minute. Now only one segment is remaining. Whenever there's a complication, just come out, remove your bronchoscope. The patient already has an endotracheal tube in. You can wait till the patient settles, whether it was arrhythmia, hypotension, hypoxia. Ventilate the patient, give colloids, give any antiarrhythmic drug if required. Just make sure patient becomes all right and then go in again. But please don't struggle to complete the procedure when the patient is not stable, because this patient is a critical patient and you don't want a sudden collapse happening. So thank you, Dr. Santa. I really liked your answer. This is the best answer. Great. I mean, this is the best thing to do. Thank you so much. So, Dr. Swami, coming to you. I think Swami just got logged out. Okay, so he'll log in. Till then, I'll come to Dr. Mansi. So, Mansi, over to you. What are the mandatory post-bronchoscopy steps in a ventilated patient that a bronchoscopist must follow? Like, like you are just finishing the procedure. You just want to come out. So, and you have come out. So, what would you like to make sure you look at? Mansi, you're muted.
So first thing is that your ET might have displaced during the procedure or the tracheostomy. So just check the position of your airway. Second thing is to check the cuff pressure so there is no leak. You can get hold from the ventilator. You also can see the leak happening there. So that has to be done. And then gradually you have to go back, going at the vitals of the patient. You can do an ABG after some time, 15 to 20 minutes later after stabilizing the patient. And then you can retitrate your settings back to the original settings that your patient was on. That has to be done. And regarding the radiology, if you have just done a BAL, probably there is no urgency to do a radiology. I mean, this chest X-ray need not be done immediately. But if you've done a biopsy, then probably you will do a chest X-ray also eventually rule out. Ultrasound is usually handy in ICU, so we usually do ultrasound after the procedure. But mostly then, you will retitrate your setting back in terms of whatever your patient's condition was. That's the usual protocol now.
Great. So, Dr. Mansi told us something very, very important. When you're coming out, please see the position of the endotracheal tube. It is very likely that the endotracheal tube might have got shifted. You don't want extubation happening. At the same time, you don't want the tube to go into one of the lobes, and then, patient doesn't get, the other lung doesn't get ventilated. And what is really important is when you come out, please auscultate the patient. There's a very high chance that he has severe bronchospasm, and you want to nebulize the patient. And slowly, slowly bring up your PEEP, come down on your saturation, come down on the FiO2 that you're giving, and if required, please do an ABG also to rule out PCO2 retention. So great, Mansi, fantastic. I'd like to come to Dr. Anand. What are intra-procedure and post-procedure complications in a patient who's critically ill undergoing bronchoscopy?
So intra-procedure complications, the most common one is the hypoxemia. And then hypercapnia. If patient is, especially if patient is having a background of obstructive airway disease, it can result in hypercapnia. And if patient is already having a type 2 failure, it can worsen. Then hypotension from the sedation and sedation related that complications, and the hypoxia itself can lead to arrhythmias and all those things. And sometimes bleed can happen with biopsy or even with BAR. And sometimes all these patients are actually critically ill with some friable mucosa and all. With simple suction itself, the patient can bleed. And so these are the most common. Then the ventilator issues, the asynchrony and all those things can happen with during intra procedure. So post procedure, the most common is again hypoxemia can continue. Sometimes the patient, the respiratory failure can worsen, and even the patient can go to a if patient is not ventilator, patient can go to a ventilator like that. Then sometimes the post bronchoscopy fever can happen, especially after a BAL. That is on another most common complication. Then sometimes arrhythmia can continue. The ongoing bleed can happen. If we have performed a biopsy, a pneumothorax can happen. These are the most common complications usually happen with the bronchoscopy.
Wonderful. I mean, thank you, Dr. Anand. You enumerated everything. So during the procedure, hypoxia, bronchospasm, arrhythmias, hypotension, bleeding. And after the procedure, you may get fever, you may get infection, hypoxia, of course. So thank you so much, Dr. Anand. This was a great answer. Actually, we just have too many questions from the audience. I think there are more than 100 questions. I'll just quickly try to take some of them. And I'll just ask to all our faculty. So I'm asking Dr. Santa. So we have Dr. Sanjeev from Delhi asking, what is the single most consistent physiological parameter that improves immediately after whole lung lavage and PAP? Quick answers, one line.
I don't get the question, ma'am. Please repeat.
After you do whole lung lavage for PAP, immediately
Okay.
after uh, WLL, which is the single physiological parameter that will improve immediately.
The oxygenation, obviously.
Yeah, so the PO2 will improve. Great.
Yeah.
So, great, superb. Now coming to Mansi, we have Dr. Ankur from Mumbai asking which lung is usually lavaged first in WLL and why?
So I think Dr. Vikas already mentioned it. The most severely diseased lung will be lavaged first, and because you can ventilate the other lung better, so that is the reason that you should be doing it.
Yeah,
Single lung will be better. Ventilation will be better for the non-disease, less diseased lung. Yes, ma'am.
okay. Coming to Dr. Anand, we have Dr. Rishabh from Pune. He's asking, what are the most common indications for performing bronchoscopy in ICU? Can you unmute yourself, please?
Mainly for diagnosis for the bowel and everything, and another common indication is for mucus flux and acute collapse.
Wonderful, great. Dr. Swami is back. Swami, can we ask
Yes,
you a
yes,
question?
madam.
Okay,
Yeah,
fine.
yeah, please,
Great.
madam. Huh.
Okay, fine. So the thing is that Dr. Anand just told us, about using bronchoscopy in an ICU, bronchoscopy in ICU to suck out secretions. So basically, the patient has acute lung collapse in ICU. How will you manage this patient?
Madam, the commonest cause of acute one-side lung collapse is always a tenacious clot or blood clot or a secretion which has thickened up or dried up. Most of the time, these secretions, you have to put the saline aliquots and try to suck it out. Most of the time, they will come out. But there are hard times whenever these secretions are really thick and they don't come out. Then the best thing is to do is to use the cryoprobe. With the cryo, you can actually freeze the clots. I have found it very useful in a patients who actually have the collapse secondary to hemoptysis or secondary to the blood clots. It easily comes out and without any, because these clots are very, they slip out whenever you try to take out with the simple forceps. So with the cryo, they can be taken out very easily. Okay, and it shortens the time period also for the procedure.
Yeah, wonderful. I just like to say that if at all you don't have cryo, and just by suction, if the clot is not coming out, if it's really stuck, whether it's secretion or you can actually use a forcep. And with the forcep, you can actually, remove the connection of the clot with the walls and then try to get it out. Great. Dr. Santa, coming to you. Very interesting question from Dr. Gopal Krishna from Bangalore. What is the most reliable intra-procedure indicator for adequate lavage clearance?
Maybe an ultrasound during the procedure. As Dr. Vikas was telling, during ultrasound, I mean, you can do ultrasound and see the disappearance of the B lines, clearing of the B lines. That may be the one rapid bedside test which can do that we have done an adequate lavage clearance or not.
Yes, and I think we can also otherwise use a bronchoscope and just go in and make sure that we suck out everything.
Yeah, that is another thing.
Correct. And I don't know if he meant something different about the lavage clearance. Another indicator also is that the retrieving fluid becomes clear. I don't know, maybe
Yeah,
that is he's
that
asking.
is better. Yes,
That
ma'am.
is, yeah,
Yes.
probably he's trying to ask, that your lavage is adequate. That means
Okay.
the returning fluid
Okay.
becomes clear. Right.
So I was thinking that the adequate removal of fluid.
No, you are right. Actually, when I thought the same, so I'll ask you one more question now because there was some confusion. So, all right, we have Dr. Amit from Meerut. He's asking, how do you select between flexible and rigid bronchoscopy for ICU patients?
So in general, we don't require rigid bronchoscopy for ICU patients except in extreme cases where we are not able to remove the clots or there is a massive hemoptysis happening. You need a bronchoscope there. You need to control the bleed and simultaneous ventilation is happening. So we very hardly use rigid bronchoscopy in ICU setting because these patients are very fragile and they are on ventilators and you need to do a quick procedure and come out and all those things. So if the patient is requiring requiring rigid bronchoscopy in the ICU or the patient is severely hypoxic for any reason, then probably really patient is very sick. So I would say the indication for rigid bronchoscopy in ICU is very, very rare. We have used in rigid bronchoscopy in some of the patients where we had massive bleeds. We could not able to control with the flexible bronchoscope. We are not able to remove the clots by flexible bronchoscope. We have used rigid bronchoscopes. And another indication could be endobronchial tumors, mass lesions which are obstructing. You need to rapidly debulk the tumors. Patient is having severe strain. You're not able to ventilate the patient. You're not able to intubate the patient with the endotracheal tube. In those cases, probably a rigid bronchoscope and removal of the tumor, clearance of the airway may be required. So I think, in my opinion, these are the two indications for rigid bronchoscope in the ICU. And
Yes.
most of the case, it is flexible bronchoscope.
Great. Yes, so basically, whenever it's something to do with the airway, so whether you want to debulk a tumor, put a stent, or there's a foreign body which can't be removed otherwise, that's the only time we think of rigid. Otherwise, flexible is always the best. Coming to Dr. Mansi, Mansi, you very beautifully told us earlier also, but this is just, I feel that a lot of people are students or juniors and they might want to hear again. So we have Dr. Joy from Kochi. Very good question. What pre-procedure preparation is required before bronchoscopy in a mechanically ventilated patient? Pre-procedure.
Oh, pre-procedure regarding in the settings, ventilator settings, you're saying, ma'am?
Yeah, pre-procedure preparation in a patient who is mechanically ventilated. So before you start the bronchoscopy.
Generally, he's asking, okay. So, the steps that we follow is that we have to optimize on hemodynamics first, optimize patient's fluid status, check on the vitals. He should be not having any sort of arrhythmias or hemodynamic instability, and then pre-oxygenate the patient well. FiO2 has to be kept at 100% for the bronchoscopic procedure. And then you optimize on the ventilatory setting depending on the need of the procedure, whether you're doing a BAL or a simple surveillance bronchoscopy to remove a mucus plug. So it's optimized on the settings. And before doing a bronchoscopy, you should always check for the patient should ideally you should keep the patient NPO, but like already has been pointed out, depends on what procedure again it's planned. So try to keep NPO at least 6 hours prior to the procedure electively if you're doing. Otherwise, you empty out the NG tube and you can go ahead with the procedure. And once your procedure is during the procedure also, you have to keep close watch on the saturation. Try to use a scope. So you should have handy all types of scope diameters with you and the airway conduit that you have. So if you have a tracheostomy tube, which is internal diameter is going to be lesser, then scope size should be at least 50% less than what you or madam has said 2 mm less than what your ET tube size should be. So you should have both the scopes, and sometimes you should be ready to anticipate that sometimes when scopy is being done and your ET is falling short of the diameter that you need, so you should be ready with a new intubation set and try to change the ET prior to the procedure so that you get maximum airway diameter to have good ventilation. And plus, when biopsies are also needed, it is very, very important that your ET size has to be above 8. Otherwise, biopsy procedures can be really tricky with those. And channels should also be, see, working channel has to be a little big. So you need a bigger ET tube. So that is mainly the thing.
So,
And that's, I think,
checklist, very good, Mansi, you've said everything. So, just to concisely tell people, a checklist is required. Make FI to 100%, make PEEP 0 or as little as possible. Please make sure that a bite block is there, oral airway is there because you're going through the endotracheal tube. And also make sure swivel adapter is present. And because the patient is mechanically ventilated, Riles tube will always be there. And therefore, you have to aspirate out all the gastric contents. So, this is something that should be done. Dr. Rishabh from Pune has said, excellent session, clear, practical, and very informative. Thank you, Dr. Rishabh. We still have 57 more questions. I'll just take 4-5 more. I'd like to ask Dr. Anand. Okay. How should post-bronchoscopy monitoring be performed in ICU patients?
So, the hemodynamic parameters has to be monitored, including your heart rate, saturations, everything. And you have to see the ventilator parameters also, like the PEEP pressures, everything has to be monitored very well for at least minimum of 2 to 3 hours post bronchoscopy.
Wonderful. And while coming out, look at the position of the endotracheal tube and always examine the patient. Yes, great. Coming to Dr. Swami. What are the key complications of bronchoscopy in critically ill patients? Dr. Muthu Kumaran from Chennai is asking. Swami, are you there?
Yes, madam.
Yes, yes,
So
yes.
the commonest complication you can create is the injury, hypoxia. The bronchoscopy itself can cause the bleeding. Uh, these are normally encountered whenever the bronchoscopist is inexperienced. There can be pneumothorax if you are doing a suctioning very hard. But if you are experienced bronchoscope, most of the time the ICU bronchoscopies are non-complicated.
Okay, great, fine. So experience is the key. Great.
Yes.
I'd like to come to Dr. Santha. So quick question. This is a difficult one, I think. Dr. Arpita from Kolkata is asking, how do you minimize aerosol generation during bronchoscopy, especially with infectious cases?
So I think we need to do in the negative pressure isolation room first of all for these patients, and wearing the protective mask for the procedurist should be the done. And we all have come through the COVID periods. So what we have done through COVID periods has to be appropriately taken care, I think, in simple.
Yeah, very good. I agree. I think over and above, I think sedation anesthesia is very, very important. If your patient is comfortable, the patient will not cough, and therefore aerosol generation also will be less. So I think that is also important. Great. Coming to Mansi, uh, how do you manage suspected airway bleeding from during bronchoscopy? Dr. Matthew from Coimbatore is asking. Must be Dr. Santa's friend. He's from Coimbatore. So
I don't know. I didn't really get his question because bronchoscopy, you're actually visualizing the airway. So you're actually sometimes using bronchoscopes to localize the bleed. So how do you suspect a bleeding with the
so I
bronchoscope?
think
You
the
can
question.
see it inside.
You're very
So
right.
what's
I
his
think
question?
probably, you are right. I think, yeah, I think probably the question is that how will you manage bleeding which has happened because of bronchoscopy?
So usually with BAL and patients, sometimes in critically ill patients, your airway mucosa is quite friable. So sometimes they can just bleed spontaneously while even you're inserting a bronchoscope or performing a lavage. And sometimes patients have tracheobronchitis due to pyogenic infections and fungal infections. So those kind of bleeds are very well managed with cold saline and add in instillation. You can manage that, and some gentle suctioning, you can remove that blood and you're good to go. So that is mild kind of a bleeding. But if you are doing procedures like what debulking procedures and other things, so you are or you're doing cryobiopsies, which is usually not done in ICU setting, but suppose your patient is too sick to be shifted, in those cases you have to have all armamentarium with you, that you need to control bleeding more. So rigid scopy and hemostasis is a different chapter altogether. But most cases in ICU will not bleed that much. So you should have handy cold saline and adrenaline with you and Tredexa. I think that should work. And sometimes post bronchoscopy, if your patient is still trickling blood, then there's a good data to show that nebulized Tredexa can be given for 24 to 48 hours. And that also takes care of the small oozes which are happening in ET.
Wonderful.
Uh,
Come to Dr.
can I
Anand.
add one more
Yes,
point?
of course, yes.
So we can use the balloon blockers in
Absolutely.
patients. So that may
Blockers
be
and
the,
foci, yeah,
Doctors,
that
yes,
can
yeah,
be done for
absolutely.
major bleeds, yes.
Perfect. Yeah.
yes.
Great. Before I'm going to ask a question now to Dr. Anand, but before that, Dr. Amit from Meerut has complimented our brilliant panelists. He said, truly impactful session. Panelists' wide expertise has added immense value and knowledge. So, congratulations to all of y'all for just being so impactful. Coming now to Dr. Anand. Actually, there are just so many questions. I'm getting lost. So, this is about WLL. What is the earliest clinical complication of WLL that typically indicates airway flooding?
Sudden
You
hypoxia from the baseline.
absolutely, absolutely
So,
perfect.
so if that happens, we have to suspect that thing. And if like a fluid is coming out from the other lung tube, all those things and mismatch between the inflow and outflow.
Perfect, absolutely. Okay, Dr. Swami, I'm asking you, which anesthesia technique is mandatory for classical WLL? Dr. Hitesh from Ghaziabad is asking.
See, for WLL, you have to give complete general anesthesia, and the muscle paralysis is must, because if you are doing a procedure, the ventilation of the non-dependent lung, or the lung which is not being, because that is also a diseased lung. So you need to have a complete general anesthesia and complete muscle paralysis.
Perfect. Excellent. Now there's a huge question from Dr. Devesh from Aligarh. Dr. Santa, I'll ask you one, two parts of it. I'll ask everybody. Where is WLL usually performed? ICU, OT, or bronchoscopy?
Ideally, it should be done in the OT because we have a large team. And yes, Dr. Vikas was already telling experienced cardiac anesthetist is mandatory. And sometimes you may have to take the patient on ECMO also. So the cardiothoracic backup OT should be the ideal place. And depends on the center's experience and center's expertise and the procedural expertise also. So if you are comfortable, we have done whole lung lavage in our bronchoscopy suite with ECMO support. So we have called in the cardiac anesthesiologist to our bronchoscopy suite, and so if your bronchoscopy suite is equipped well, then probably you can do in your suite also. But ideal place is the OT, I think.
Great. Actually, he's asked 4, 5 more questions, but I think we've just finished discussing them, so I won't ask them. I'll come to Mansi. I think the last round of questions, there are 53 more questions, but I think we'll just do 2, 3 more and stop now. Coming to you, Mansi. So we have Dr. Gaurav from Indore. He's asking, what is a typical lavage volume used during the procedure?
So what is mentioned is literature is around 500 to 1000 aliquot per aliquot you can give, and the range is between 10 liters to 40 liters. But as I said, it is nothing, this is all customized as per the patient. So we can start with a volume of 500 ml. By and large, most patient of adult patients of our in Indian patients, 750 ml is what we have used per aliquot. So that can be given, and 15 to 20 liters or 25 liters is maximum that we have been able to do for one lung. So I think that is, but there is no rule, as I can tell you that, but aliquot has to be for 500 to 1000 ml. So whatever your patient, if your patient has been able to do for milder cases, if your PFT was available, like sir was saying, FRC measurement could be an option.
Okay, so great. I'll just ask Dr. Anand before that. We've some fantastic questions. I mean, fantastic comments. I'm sorry. So Dr. Uday, our friend from Goa, we know him. So he's written outstanding session, informative, inspiring, and very, very learning. Very wonderful presentation by Dr. Vikas also. Panels were excellent. Thank you. Great. So, okay, now coming to Dr. Anand. There are just so many good comments as I come through. I'm just telling them. Dr. Anand, which bedside sign indicates overdistension of the lavage lung during WLL?
Ultrasound and B lines in the ultrasound you can actually use.
Correct. Okay, fine. I think this, let's keep this as the last question. Swami, coming to you. Name one absolute contraindication for WLL. Dr. Ronald from Kolkata.
If you are not able to maintain the oxygenation after putting the patient on the double lumen tube and single lung ventilation, if you are not able to maintain the patient on single lung ventilation, then probably you should not go ahead with the whole lung lavage or the single lung lavage.
Great, wonderful. You know, you all have been fantastic. There are still 45 more questions, but I think what we'll do is that, we'll write them back, the answers. Again, a wonderful comment by Dr. Rajiv from Gurgaon. All panelists' perspective added tremendous value and made topic whole lung lavage exceptional. Thank you, Dr. Sardha Kumar, Dr. Swami, Dr. Mansi, Dr. Anand, Dr. Vikas, and Dr. Amita. Great. So I think also a masterful explanation of challenging topic, deeply appreciated. Thank you so much, Dr. Amita ma'am, for fantastic moderation. And thank you all the panelists for the fantastic information. Dr. Joy from Kochi, probably you know Dr. Anand, Dr. Joy. You might be knowing he's from your city. And brilliant discussion. The clarity, the depth and enthusiasm made discussion both memorable and impactful. Thank you, IIB, for organizing such fantastic webinars. Dr. Naman from Gurgaon. We have many, many fantastic comments and we have many, many questions pending. But I just want to thank my most learned, most distinguished, and most amazing panelists for giving us so much information, for making sure that the discussion was so lively. You all are very crisp, you all are very precise, and I think at least I have learned so much today from today's webinar. A request to each of our panelists to just say one or two lines before we end this fantastic webinar, which has had 2256 logins, 2256 logins. Starting with Dr. Santa.
So, especially, first of all, I want to thank Dr. Amita for giving me this opportunity. It's a wonderful session I could join. And really, I learned a lot of things from this webinar, more than being a panelist, I learned a lot of things here. So, thank you very much.
No, you're being very nice. What I meant was one take-home message, either on WLL or bronchoscopy in ICU.
Yeah. So, WLL, as I told initially, it is a very highly invasive procedure. It's not needed in all patients. You need to select patients and you need to do in appropriate settings with a good team. And the patient should get really the benefit of the whole lung lavage. That is regarding lung lavage. And ICU bronchoscopy, as you told in one of the answers, it should be a very short procedure and very specific areas of lavage and reduce the procedural time and hypoxia. So that's what I would prefer to do.
Wonderful. Mansi, what would your take-home messages? One for WLL and one for bronchoscopy ICU.
So take home combined for both the things.
Okay.
They are highly specialized bronchoscopies in be it ICU or WLL. So I think for beginners or residents, assist more and more procedures so that you learn by observation also, because you have to learn before you perform. These procedures are highly challenging actually.
Great. Dr. Anand, were your words of wisdom and your advice to all of us? For one for WLL, one for bronchoscopy in ICU.
So for whole lung lavage, basically we need to select the patient very carefully, and who is required for that, who requires that procedure, that has to be selected very well. Second, for this ICU bronchoscopy, it is not a procedure which we cannot do. It is always we can do it, but proper selection of the patient and the ideal thing, everything has to be keeping ready, and you have to do it fast. That's it. Careful procedure itself can yield the fruit.
Wonderful. Sami, what would you like to tell us?
For ICU procedure, yes, you have to be very, very precise. Your indication should be very clear, and what benefit you are going to get from the procedure, you should be very clear about it. Your plan of action after bronchoscopy should be it should be planned very nicely. For whole lung lavage, it is very, very important that this procedure is not a single procedure. For the same patient, you may have to repeat it again and again. So you have to counsel the patient very well when you are subjecting the patient that this is not a single procedure. You may have to repeat it again, and it is very, very important, I feel, to tell them. Thank you, madam. Thank you.
Wonderful. I think we've had one of the best webinars today. Dr. Vikas set the ball right, by giving a fantastic talk. And, all our panelists, all the very, very learned four panelists have taken our webinar to some other level. I kind of feel each of you all, again, as I said, have been extremely precise, extremely knowledgeable, and you all have also transmitted knowledge in such a nice way. So once again, I'd like to thank Dr. Santa, Dr. Mansi, Dr. Swami, Dr. Anand, and Dr. Vikas. I'd like to thank IIB, and I would also like to thank Mankind, especially Nitin, and also Olympus for being our academic partners. Thank you so much, and good night, everybody.
Thank you,
Thank you.
madam.
Thank you,
Thank
ma'am.
you. Good night.
Good night,
Thank
ma'am.
Thank you, ma'am.
Thank
Good
you.
night.